just missing a vice chairman, but never mind. Right. Good morning, everyone. Welcome to the Health Scrutiny meeting. Welcome to our guests and welcome to Ajanta. Nice to see you, Ajanta. Right, so first of all, members, we have the minutes of the last meeting. Do I have approval to sign those, please? Thank you. A seconder? Anybody? Thank you. Right. Apologies for absence. Do we have apologies?
Chair, if we could just take that maybe slightly later. Councillor Barney's just checking what the story is with Councillor Cobley, so we can report that in a moment when Councillor Barney returns. Oh,
well, now we know where he is then. That's fine.
Yeah.
Right. Item number 3, declarations of interest by members and officers. Disclosable pecuniary. Anyone? Councillor Welch, Councillor Wilmot.
I'm not sure if this, but I thought I'd better say it anyway. One of my best friends works in neonatal, but
well,
QMC.
We might as well have it down.
So I thought it was best to just declare that. Thank you.
I think if in doubt, declare it. It's the easiest. Councillor Gowan.
Excuse me. I work with some of the
and Nottinghamshire. Dr. Lee is going to take you through some case studies which will bring to life what this particular service improvement will really mean, and then I will conclude with a request for support from the Scrutiny Committee, obviously subject to today's conversation. So if I just briefly open, and as the paper says, Nottingham University hospitals and therefore the population of Nottingham and Nottinghamshire have an opportunity to access NHS capital funds to increase the number of neonatal cots at the Queen's Medical Campus from 17 to 38. And subject to gaining support from health scrutiny committees, the business case for this will be approved in time for the cots to be ready to take babies in 2023. As the paper describes, NUH provides a neonatal service to patients beyond Nottingham as part of a national and regional network. And there are 3 levels of care provided to premature babies. There is intensive care, there is high dependency, and by way of correction to the paper, what is described as special care is actually a local neonatal unit. And if you want any clarification around sort of categorisation, I'm sure Dr. Lee can provide that. So the paper in the table does describe how the reduction in provision at City Hospital can be seen in the context of increased provision at QMC campus. And it also sets out that this development, if approved, will result in a net increase in capacity for neonatal cots in Nottingham of 13. The paper describes how this will increase capacity across the whole of the network that NUH serves. And whilst the increased provision isn't allocated specifically to Nottingham patients, it will de facto increase access for Nottingham and Nottinghamshire patients. So Dr. Lee is going to describe in real terms what this will mean to mothers and babies by taking you through these patient stories. But in essence, just to finish from me, the significant benefits of this increase in specialist cots are twofold. Premature babies from Nottingham and the wider region will not have to so frequently travel long distances for specialist care, which reduces the risks of physical transfer and keeps families close together at what we can only recognise as a very difficult time. And secondly, ensuring that where the most fragile babies need access to specialist support, diagnostics and surgery, they are co-located at QMC where this support is available. So I'm going to hand over to Dr. Lee now to explain to you what this really means.
Thank you, Lucy, and thank you for inviting me. The first patient story is to describe the journey that our patients currently have because of a lack of capacity at NUH. Mrs. P is booked to deliver her twins at Queen's, so she's expecting to have her babies at Queen's, but she has an emergency cesarean section at 26 weeks. Post-operatively, she's unwell, but unfortunately there isn't enough capacity at the Queen's Neonatal Intensive Care Unit to look after her babies. And therefore what we do is we use our transport service to ring around and find appropriate beds for them. And tertiary neonatal care could be at Leicester, which is what I've described there, but it could be at another tertiary centre outside of Nottingham and outside of Leicester. Oh, sorry, I'm moving away.
If you could just pull it a little bit nearer.
Thank you. The twins are transferred to Leicester on their day of birth, but Mrs. P is unwell, so she remains at Queen's. Her partner is therefore travelling between Leicester and Nottingham in order to see the babies and to see the mother. 1 week later, because we do try to get them back as soon as we can, the twins are retransferred back to Queen's when there is capacity available. So that's an example of current provision. What we're hoping will happen in the future is that Mrs. P is booked to deliver her twins at Queen's. At 26 weeks, she needs to have a cesarean section, and she has that section at Queen's, and the NICU has enough capacity to keep the twins at Queen's, and therefore the family aren't separated. Her partner is not travelling between 2 cities in order to see his wife and also to see the twins. Can I have the next slide, please? So I should say in the first patient story, had we had capacity at City in our current provision, we would have moved the twins to City, but within the whole of Nottingham, there wasn't any space, and that's why they had to go to Leicester. So this one is particularly about the QMC at Queen's. We've called her Mrs. M. Again, at 26 weeks, she has her twins. Unfortunately, Queen's doesn't have capacity, but City does. So we moved the twins over to City, which is what we would currently do. We try really hard, if at all possible, to keep our babies in Nottingham. Unfortunately, one of the twins developed a surgical complication a week later. Now, this paediatric surgery is at Queen's, and so that twin then has to be transferred from City back to Queen's. So that's their second transfer in 1 week. Now we have Mr. and Mrs. M travelling between Queen's and City because they have 1 twin at the City neonatal unit and 1 twin at the Queen's neonatal unit. Eventually, because we keep on trying, we do get the twins reunited. So the second twin is transferred to Queen's to be with her twin sister, and now the parents can concentrate on both babies in the same unit. In our future, we hope to have enough capacity within Nottingham in order to do this. We hope that Queen's would be our properly capacitated tertiary intensive care unit. and therefore we would have enough capacity at Queen's for both of the twins to stay at Queen's. When the second twin has its need for surgery, it won't need to travel because the paediatric surgeons are at Queen's, and therefore all of that is managed in a far more timely way. The twins stay together, the parents stay with their twins. Can I have the next slide, please? And the third story is really telling the story for the mother who's booked currently to book her twins at City and to deliver them there. So Mrs. D, she's booked to deliver her twins at City, and again at 26 weeks, she requires a cesarean section, and they're admitted to the City neonatal unit. 1 week later, one of the twins develops surgical complications. Because we don't have paediatric surgery at City, that twin is then transferred to Queen's. Again, the family are separated, and Mr. and Mrs. D need to travel between City and Queen's in order to see both of their babies. We continue to try to get the twins together, and eventually we get the second twin over to Queen's, which is where the surgical input is, and so the direction of travel will be from City to Queen's to reunite the family. In the future, Mrs. D is booked to deliver her twins at City. At 26 weeks, she would fit criteria to be delivered in the purpose-spec Queen's Tertiary Neonatal Intensive Care Centre, and so the twins would be born at Queen's. Therefore, when one of the twins develops its surgical complications, the family aren't separated and care continues together with the family together.
Thank you. So I hope that those three case studies have given you a flavour of why we as commissioners are very supportive of this proposal, and particularly keen to enable NUH to access the capital to make it happen as quickly as possible. Our intention, as the paper says, is to deploy a targeted engagement approach to ensure we do consider this to be a very positive service development for Nottingham and Nottinghamshire, and we are really keen to work with our communities as we move forward. Our sense is that this isn't a major service reconfiguration that would benefit from a formal public consultation, but clearly subject to receiving your assent to proceed on this basis, we are very keen to return to the committee, subject to NUH securing the capital as the proposal develops, to provide you with the assurance that you will require that the voice of our citizens is appropriately shaping the final solution. Thank you.
Thank you very much. Thank you to both of you. Can I just check, did you say it would be 2023 before the unit?
It would. So the sort of timescale now is that the regional neonatal network are ready to consider the business case. So they're waiting for us actually, and the last big piece of that journey is for Scrutiny Committee to support, or indeed otherwise, of course. If we are able to say that as a county and city we support this proposal, then the business case will go through the process. The capital will be released, the building works will take place, and the unit will open in 2023.
Thank you. Thank you very much for that clarification. So, Councillor Wilmot.
Thank you very much, and thank you very much for your presentation. It's very enlightening, to say the least. Can I say I wholeheartedly support the expansion of the neonatal service at Queen's Medical Centre from 17 to 38. That's what it says, by 2023. As the appendix to the report states, between April 2019 and April 2020, there were 147 transfers between sites, with some babies having to be transferred as far away as Burnley, Luton, Scunthorpe, Bradford and Birmingham. I welcome this short-term change, and note that the reason for this only being short-term is because of the new hospitals programme. Can I have an assurance that in the light of the current delays and spiralling costs of major infrastructure costs, that this will be extended until we get our new services? And in paragraph 3.3 of the report, it states that the lack of capacity on neonatal services has increased risks of cross-infection and mortality. Can I say on what evidential basis this sentence is being used? And between April 2019 and April 2020, how many babies subject to transfer were cross-infected or sadly died due to being transferred? And are the figures available for April 21 and for April 2021 to? Yeah, historically, when did this issue come to light at the newborn intensive care unit? And for how many years were we aware of capacity issues that directly led to our babies being put in danger? And I'd like to just say to you, I'm a bit concerned at the reduction at one of the hospitals because of the amount of homes that's being proposed over the next few years. It could be up to 600,000 new homes in and around Nottinghamshire and Nottingham. I just wondered, with that sort of capacity that you're going to have, will you have the capacity at the city hospital to carry on that work? And of course, the other issue is, of course, parking. Is there going to be a special area for parking for these people? Because it is a serious situation when people need to get parking spaces. And of course, there isn't a special parking space for that kind of the people who need to get in there to see their loved ones with the possible problem with the baby. I'm sorry it's a bit baggly, but
No, thank you, Councillor Wilmot. Thank you actually for taking the trouble to read the paper in such detail and understand the subject matter, because your questions are all entirely relevant. So if it's okay, I'm going to take 3 questions and ask Dr. Lee to take the sort of questions about clinical care and safety. So if I just start with, is this a short-term proposal, and is it going to, is it going to provide enough capacity until the new hospital can be built? Absolutely. I think what we're saying is that based on our current projections, were we never to build a new hospital in Nottingham, which clearly we want to, this capacity should see us through to the medium term. And what we're actually saying is we can't wait for the new hospital. So this is good news. We're getting this capital now for Nottingham to tide us over until the new hospital might be built. So it's a really good thing. So hopefully that answers that question for you. In terms of population growth, I mean, I think it's 2 separate questions, isn't it? Have we got enough capacity generally in Nottingham and Nottinghamshire, and where should that be? I think what Dr. Lee has described is that if for neonatal care, particularly the most specialist neonatal care, it needs to be co-located with the other services that Queen's can provide. So it wouldn't be, that probably wouldn't impact on capacity at City. That's about putting the extra capacity into Queen's. And for me, your final question about parking, it's a really good question. In fact, I've spent part of this week talking to colleagues at NUH about how they are going to look to provide some additional car parking, again, as an interim measure between now and when the new hospital is built. So that is very much on our minds. Thank you. If that's okay, I'm going to ask Dr. Lee to talk to you about the clinical safety issues.
Thank you. If I forget any of your questions, please do come back to me. The 147 babies, they were transferred between Queen's and City in that year 2019 to 2020. I don't have the 2020 to 2021 data at my fingertips for you, unfortunately. Those are babies who were transferred between sites because either Queen's was at capacity and therefore we needed to move babies out of Queen's to City so that we could take more babies into Queen's. It tends to be that way because Queen's is our paediatric surgical centre. And so if we need neonatal surgical intensive care, we need to create the bed at Queen's. At the same time, we do sometimes transfer from City to Queen's as well for capacity purposes because there are ebbs and flows in the occupancy of both units. But you'll notice in the paper that Queen's, very often, we ought to be at 80% capacity. That's what our service spec says. Very often, you'll find that Queen's is running at 90, 100 and over 100% capacity. And it's at that time, those times that we're needing to transfer for capacity, and similarly the other way for City. In terms of the risk of infection, that is related to the fact that the Queen's neonatal
the work is that goes on with regards to neonatal units, the complexities of each individual case, which can be very, very different for each baby, is quite extraordinary, and the level of skill and determination and emotional drive by the staff, I know that from the staff on there, is extraordinary at times, going way beyond really what is expected of them. A lot of the time it is a job of passion, I think, for the people that work on there. So I'd just like to start by saying that and making that quite clear. I have a couple of questions that I scribbled down as I was thinking, and it's all kind of jumbled up. So I'm going to do my absolute best here. We're talking about 2023, and we're talking about increasing the capacity, which is greatly welcomed, I think, and probably welcomed by most people. My question is, in light of what's going on nationally with regards to staffing in hospitals and having the appropriate amount of staff, is there work taking place now, if you're increasing the capacity, to ensure that those that are working there already we don't have a situation where they're doing the jobs of 2 or 3 people, and therefore that health is ever compromised, and whether there's kind of a going on. I was reading a report not so long ago, which was commissioned by the National Institute for Health, conducted by the National Clinically Advisory Team, where it talked about neonatal units. And this is, I think, that people don't understand the intensity that's on there necessarily. And I wouldn't say that I do fully, but having conversations with my friend, the amount of attention that can go into one. So they say for an intensive care, it's 1-to-1. But then when you talk about high dependency, for every one baby, you're looking at 2 staff members. And then when you're looking at special care, it's 1 baby and 4 staff members. So if you're increasing the capacity in the way that you are, that is going to put pressure on the current staff, and it's going to mean a big recruitment drive, isn't it? And I'm fully aware that at the moment, other neonatal units across the country are finding it incredibly difficult to get those people to work on those units. So I welcome the increase in capacity. I think it's absolutely fantastic. And, you know, I actually had a friend that had a baby unexpectedly, way before she should have, while she was up in the Lake District, and baby ended up in neonatal up there, and then eventually ended up in Lincoln. And it was all very difficult because the dad wasn't able to see the baby. And so anything that we can do to increase that capacity and to help the friends is absolutely amazing. But I think what I would want is some reassurances that we can actually do the care that I know that you so desperately wanted to do. The other thing that I wanted to highlight as well is, when you increase the capacity and you're looking at the way neonatal is run, are you, and I know that you are, but I'd like some clarity around it. How are you incorporating the kind of the parent experience in all of that, with regards to, so obviously they'll be closer to home, which will be absolutely fantastic, which is very important. But is there a room that they can go to? Is that all in with this increased capacity? Is there somewhere where they can make a cup of tea? Is there somewhere where they can make their toast? This all sounds like quite trivial, but when you've got a baby in that situation, these things are really vital, aren't they? You know, to sit down with a cup of tea and a biscuit, you know, you know, it seems trivial, but actually it really, really matters to mothers and fathers and whoever's there, the carers. So it's how you're incorporating the whole holistic approach as well with families with regards to that. So staffing capacity and how you're incorporating care of the families would be my 2 main questions. And the other point is that, you know, thank you for doing this because it is so desperately needed.
Thank you.
Thank you for your questions. Thank you for your really kind comments about our staff. Our service is what it is because of our staff, and they're amazing, so thank you. If I take staffing first, absolutely, if we are going to increase our capacity, we need to have a plan in place for increasing our staffing. If I can just correct one thing though, for the intensive care, 1-to-1 means one nurse to one baby, because those are our most intensive care babies. Our high dependency babies are the level down from that, so it's one nurse to two babies, and our special care are the ones who are the level below that in terms of intensity, so it's one nurse to four babies. Just to spin it around a little bit. However, you are right, we will need more nurses and we will need more medics and we will need more allied health professionals to look after a unit with increased capacity, and we have business cases going through for all of those. So we have business cases to meet, it's BAPM, British Association of Perinatal Medicine. They've set the staffing standards that we should expect in neonatal intensive care units based on the type of unit you are and the type of baby that you have. And using those ratios, we are getting our current staffing to BAPM levels. And we have business cases going through to ensure that we, at the end of December 2023, which is when we would hope that we have our 38 cots, we've got the staffing to match it. So there's a medical case running through, there is an allied health professionals case running through, and there's a nursing case running through, so that we can hopefully marry up those timelines, because it will be recruitment after recruitment, training, making sure that we're running a really safe service all the way through to and beyond the expansion to 38 cots. And we have oversight of that from the East Midlands network as well. So we're part of the East Midlands Neonatal Operation Delivery Network, and we meet with them regularly. There's a whole intensive care capacity oversight group, and that's part of what we are working through with them very carefully, with the specialised commissioners, with the national commissioners as well. Parent facilities, absolutely. Not trivial at all, and definitely need to be in there. So within the new plans, as we're walking them at the moment, we do include family bedrooms, family counselling rooms, family a bereavement room for those very sad family cases, with shower facilities. We have visitors' toilets, we have visitors' lockers, we have a nappy change, and a coffee room. So we're hoping that we're able to make them as welcome as possible on the unit.
And Chair, if I may, on that, just in terms of where we are with this development, so what we're asking today is for approval to kind of just press the button on the next stage to get the capital funds released. And if you are prepared to support us in doing that, then as the paper said, that's exactly the kind of thing we can come back and talk to you about. So as the commissioners, we'll work with colleagues in NUH, and we can talk to you about how we're going to engage with them and how the public can shape those sorts of details. But what we want to do really now is just get to that next stage.
Thank you for that clarification. Before I move to Councillor Martin, can I just clarify? You can either do a targeted consultation or a full public consultation. And what you're actually saying is the targeted consultation will be more direct with the people who are using it rather than the wider consultation. And presumably that would take longer anyway.
Yes, it would, Chair. And just to be clear, what we would like to do is targeted engagement. So not a full public consultation where we would, ask the opinions of all of the public, but if we can get a sent support today, we can get the business case going through that, which starts to release, to earmark the capital funds. And then we continue to work with the public, and we will come back to you because you clearly, will want to ensure that we're responding to anything the public might say without a full, broader public consultation.
Yeah, thank you. So that's clarified, members. We know what our final decision will be today if we agree with a targeted consultation. Councillor Martin.
Thank you, Chair. Yeah. As your report says, there was 147 transfers during this period. Are you convinced that the expansion and the rejigging of moving people from the city to QMC is going to be enough, considering, like Councillor Wilmot says, there's going to be around about 60,000 houses built across the county in the next 15 years? Do you think the capacity will be enough, and does it fluctuate, or is it sort of regular? Are there periods where, because Burnley and Scunthorpe, not so much Scunthorpe, but Burnley and Bradford are quite a long way. I presume that you only go to those places because they've got specialist beds that those patients require. Is that the point?
So again, I think there's probably a clinical answer and there's a more general planning answer. I think we work with regional and national planners for neonatal services, and their projections indicate that based on population health demand and what we know, we can see about population need, that this is the shortfall in the medium term. But I absolutely agree with you. So this, this is not an insignificant capital investment. To get us something better, we can't wait until we have the new hospital. And I think that the national and regional planning suggests that this will certainly meet demand in the medium term. But you're absolutely right. When we come to do the detailed planning for the new hospital rebuild, we will take account of those sort of bigger population health changes. I think this is, I mean, Dr. Lee will explain there clearly will be fluctuating demand now, but I think this is kind of our medium-term plan.
Thank you for your question. What we're aiming to do is have enough capacity within Nottingham to look after all of the babies that we currently don't look after in Nottingham and ought to as the tertiary centre. That includes Nottingham booked women and Nottinghamshire booked women as well. Many of those transfers are because we don't have paediatric surgery at City, and we don't have anything other than plain chest and abdominal x-rays really at City, and therefore if you need any of that input, you need to go to Queen's for that. So there are two chunks, if you like, of reasons for that transfer. One is the capacity, and we're hoping that we will be able to fix that problem with having the increased cost, which has been modelled, as Lucy has said, and the other is access to those specialised services. It is the most preterm who we are hoping we will then deliver at Queen's who are most likely to need those surgical services. So we're hoping, yes, that we will decrease that need to travel, particularly when you are at your most vulnerable, when you're at your most preterm and when you're in your early stages of your life.
Happy, thank you. Councillor Gowland.
Thank you. I just wondered, we can't wait, obviously, for a new hospital. I mean, frankly, it could be well beyond any scale that we can imagine. I've heard over the years of discussion about a children mothers hospital at the Queen's. Is this part of that development? And particularly, I was quite shocked really to read about the infection control in the appendix. And there's a section here about the obstetrics theatre space, which I feel maybe I'm not reading it right, or I think it may be like not quite, the English isn't quite right in it, but is this related to the Queen's? And is it saying there's one theatre at the Queen's for complicated obstetric cases? And if so, will that also be addressed as part of this plan?
Thank you. So it is also about increasing the obstetric theatre capacity at Queen's. It will be at Queen's. Inevitably, while we're looking at this increase in capacity, we needed to make sure that we had sufficient obstetric theatre space.
And I think your question about the longer term aspiration through tomorrow's NUH is to have a dedicated women's and children's hospital, which would include these facilities. But as you quite rightly say, we can't wait. So this is the interim solution. And this is why we are so keen to just get access to this capital now.
Thank you. Vice Chairman.
Thank you very much. I'd just like to say I absolutely wholeheartedly welcome these proposals. It's absolutely fantastic. My question's really been answered, I think, but I just drill down into it slightly more again. It's about capacity. So this is an interim solution to get us over to where we need to with a re-hospital building programme. But as Councillor Gowland has alluded to, that might take years, may never happen, who knows. At what point would there be a refresh of these numbers in that instance, in case the hospital is 10, 15, 100, a million years off? Thank you.
Well, I will have to say on the record that we are heads down. Our intention is to open the new hospital in 2030. If for any reason that isn't, and we will be coming back to you early in the new year with our broader plans for engagement about the new hospital, which, as I say, is currently scheduled to open in 2030. But you're absolutely right. If for any reason that doesn't happen, all of the changes that we are trying to deliver through the new hospital will have to be considered. And Dr. Lee talked about hospital building note standards. We're not alone in this, but Queen's was built in the 1970s. It was built to space standards that were okay then. They're not okay now. Even the City, the maternity unit's 30 years old nearly now. So we need tomorrow's NUH to address, we say, you know, a hospital fit for the future. If for any reason we can't deliver that within the timescale that we currently believe we can, we'll be revisiting all of these critical proposals.
Thank you. Happy with that. Councillor Adams.
Thank you, Chair, and good morning. Just a couple of questions, really. Touching on the capacity issue, I just wonder, at the moment, the 95% at 80% of the time, does that include babies from other areas coming into Nottinghamshire? And if so, with the extended capacity that we will create, is there a cut-off point where you would determine that, I don't know, let's say if there was 10% available or something like that, then would that be a cut-off point to say, well, that needs to be kept in allocation for Nottinghamshire babies, or does that then subsequently be part of that, you know, that transference of babies from other healthcare areas? That's the first thing. Sorry to point, I didn't mean to. The second thing, absolutely support your effort to improve the service and expand it. I also wonder what best practice are we utilising to design these new locations? Is there something around the measuring of the footfall of the different sections? You mentioned there about a theatre. So are we monitoring footfall of certain locations, and therefore when we go to then design these new ones, are we incorporating that and accessing information from other sources, maybe it be national best practice, to determine what we need and what we don't need? I think there's one more thing. Oh, and finally, what measures we'll be taking to measure its success? Thank you.
So just very quickly from me on the best practice in terms of design, there's two aspects to that. There is what is called, you know, what are called hospital building notes. So there is accumulated best practice, which again, as I say, changes over time, that says that typically a neonatal cot space should look like this, down to, you know, how many sockets it should have, so we, and similarly with theatres, and of course that, as I say, that is fundamentally different when both Queen's and City were built. So we will use those, and it's sort of, you know, it's national evidence based. We'll use those, so that gives you the spaces, but then of course the capacity is a different matter, how many patients you need to get through, and that's something that our clinical colleagues will work on. So so those, you know, so just to assure you from a design perspective, yeah, absolutely we use best practice. I think probably Dr. Lee is far better positioned than me to talk about how you transfer patients under pressure.
Thank you. So I think the 95% you're referring to is that we should, in Nottingham, as a tertiary neonatal intensive care unit, accept 95% of those who are the specification of babies who should be born in a labour suite that has a tertiary neonatal intensive care unit attached to it. I think that's the number you're talking about, which will, as you rightly point out, include the whole network, because we are a network tertiary centre. And so if you go into labour in Lincoln and you are 26 weeks and you can get to currently either of the sites in Nottingham, ideally we would transfer you in utero, and that's a whole Midlands wide network guideline to do that, so that you actually deliver in the right place, so you have your best start to life, and that's based on evidence of outcomes and places of birth versus outcome. In terms of whether there is a cut-off for NOTS babies, on a baby by baby basis, if you're booked in Nottingham, when you go into labour at 26 weeks, you will come into Nottingham. So if you're booked in Queen's or City, that's where you will come into. If you are booked in another hospital within the network, we have a really well-developed neonatal transport service, and that transport service will do the cot locating to find the delivery suite and find the neonatal intensive care unit that have capacity for that baby. Does that answer that question?
Yeah. Just to I suppose what I'm trying to sort of work out is this actually going to solve a problem for us in Nottinghamshire, or are we solving a regional problem by doing this in Nottinghamshire? So, and should what befalls on other health areas, locations within the region, to also ensure they're up in their game, to ensure that we are getting a an overall, and so the pressure doesn't come into Nottinghamshire, that the pressure then is spread around the whole of the district, the whole of the region, I should say.
That's a really good question. When we got the report from the National Critical Care Transformation Review, the neonatal network took the lead on looking at all of the network hospitals, all of their activity, all of what was or wasn't done and what should be appropriately done. For us in Nottingham, we need to make sure that when babies who come into Nottingham are ready to return to their base hospitals or booking hospitals, they're able to go back. And so each hospital has its own plan for how it contributes to the best working of the flow of babies through the network.
All right, happy. Ajanta, would you like to put your question forward?
Thank you, Chair. Councillor Adams has perhaps taken one of my questions in part, but I'm slightly more confused than not with the answer. So if I just continue with that, what Councillor Adams was talking about. So in your presentation as well as in your paper, you're saying that while you're increasing capacity, you do accept. So while we had 116 patients going elsewhere, so you will accept babies nationally from wherever. And does that mean that will there be some beds allocated to local, or is it the case that all the beds are full, another 26-week delivery is coming in, and we will be in the same situation where we don't have a cot for the premature baby, and that baby ends up going elsewhere? So it's a follow-up, I suppose, from the question. The second question was is still on access, that if there isn't an allocation, then how much of it is going to be sucked up with the national requirement? Because we might be allocating, you are asking here the scrutiny committee to get the funds to build this hospital. But if the national is not, it feels that the staffing question that Councillor Welsh was talking about, that everybody is competing for that very limited capacity of trained medics, trained nurses. So it feels that, is this a national part? Are we one cog of the national planning? Or is this, we are building capacity for access to national patients? That was my question. The second question is on patient experience, which I'll come back to. But if I can move to 116 babies, you said were transferred from Nottingham in 2019-2020. Just for the sense of perspective, are you able to tell us that how many, is this 116 out of how many? So if it is 116 out of 120, that's a huge number that are being transferred elsewhere. So just trying to get a sense of perspective that how many were transferred. That's my first on how many. And the second is how many were actually transferred to Burnley or Bradford? Is it just out of 161 was transferred to Bradford? So it's just getting that sense of perspective. If you don't have that data today, it would be helpful, I think, to have that data. Can I move to my other question, third question, for patient experience? It appears from this proposal that while you intend to do engagement with patients and you intend to look at the data from previous patient experience, none of that has happened as yet while you are building this proposal, which is disheartening because, I don't know why NUH doesn't engage or doesn't look. You already have the data of previous parents who have gone through this experience, who were transferred elsewhere. Was that data collected at that time, their experience of having mum here, newborn baby elsewhere? Was that experience already collected, and why was that data not looked at this initial stages? Why is there no PPI at this initial stage giving you the input in forming this proposal even at this initial stage? While you're talking about that it'll be a targeted engagement, it feels that it's almost an afterthought and not thought at the first step when you are thinking of proposals.
So if I just sort of give you a start in terms of the Commissioner perspective, It is complicated the way that neonatal services are commissioned and provided, and actually, you've got the session on the healthcare bill later. But until now, as local commissioners, we wouldn't have been particularly engaged in a proposal like this, because this was all run. These are called specialised services, which, as you know, are commissioned by NHS England on behalf of our populations. So we have to say, today find it really this is the beginning of a new way of working, and it's great that as local commissioners we are part of this planning. But I must just and therefore we have the opportunity to talk to you, and we have the opportunity to really work with our local population in a way that the kind of national and regional planning process isn't intended to do. So the national and regional planning process, there is the neonatal review that Dr. Lee mentioned. It's very much a kind of a looking at population health data, how many, what's happening in terms of trends around numbers of neonatal babies being born, and just it's that very much that planning piece. What capacity do we need across our national and our regional networks? And that's the planning work that has been done. And it hasn't just been done for Nottingham. It did show that Nottingham has a particular deficit, but it's been done nationally. And actually what we see this as is an opportunity for us as local commissioners and you as representatives of your population to get involved in a way that we maybe wouldn't have done. And it is a real opportunity. So that national review is saying there is a shortfall of capacity nationally. What that means for Nottingham is you need 13 additional cots. That's where we are now. So it's sort of demographic and epidemiological planning, and subject to developing a detailed business case. There is a considerable sum of capital money that we can access, and that's where we are today. And we see that as a real opportunity. So I think just really to contextualise, Janta, where we are, we're responding to a kind of national review process, and we think it's great, and we want to get involved in it. So that would be my first comment, and we can share with you. I don't know whether we've got any hyperlinks, but if we haven't, we can share with you the national review documentation, which describes how that planning process happens. But as I say, to reiterate, it's great that we can now be involved in this locally. So in terms of patient experience, I mean, I think I would hand over to Dr. Lee for this, but so it's been a planning process to date, as opposed to an epidemiological population health management planning process to come up with a quantum of requirement. But I'm sure that Dr. Lee can explain how you do ensure that the development of the proposal even to now is informed by patient and family insights.
Thank you. So in terms of our families within the network, we have a network parents group, and that parents group is very active, and they're able to inform the plans that the network have made. In terms of our place nationally, we are one part of a much larger national plan. The Neonatal Critical Care Transformation Review looked over all of the neonatal units, and the other report that we have is our Getting It Right First Time report, which again was a national look at all of our neonatal services, for which we can see that Nottingham is really is one of the worst in terms of how our services are organised and our staffing. So we really do have to get this right, and we do need to get it right for our babies and for our parents. We don't get lots of complaints from our parents, and that is a testament to our staff, because we do move our parents and we do move our babies, and as staff and the people providing the service, that is something that we deal with on virtually at least weekly, if not a daily basis. So that is something that is a constant in our working lives, moving babies and parents around. And as Lucy said, therefore, this is the opportunity to make sure that we can do something about that we can increase our capacity. In terms of that, what happens when the next baby comes in, and what happens if that is a Nottingham booked woman who comes in, the numbers were worked out regionally and nationally. So within our network, we are the tertiary centre for the north hub of the network. Leicester are the tertiary centre for the south hub of the network. But both, we even have greater oversight, because though they were separate neonatal networks, they are now one network. So we have the same network team who looked at those data and gave us really good data on how many cots we needed to increase by in order to do that work that we were sending out of region, sending out of Nottingham, and we were sending out Nottingham booked, we were sending out Nottinghamshire booked, and we weren't accepting those who we should accept from the network. So this number will allow us to do all of that for all of our population. It's important to say that it isn't just intensive care cots. As you say, there will be some babies who are Nottingham booked, Nottinghamshire booked, who don't fit the extreme preterm. And so we do need to make sure we've got enough special care capacity in Nottingham so that as these babies get better, they can stay in Nottingham and we can look after them here.
Thank you. Thank you. I don't think I've got anybody else who's wanting to ask a question. Can I check that there isn't anybody that wanted to ask something that hasn't done so? Fine. Well, thank you very much for coming, and I'm sure, Dr. Lee, you're busy today, so very grateful to you. We have a recommendation on page 13, and obviously we're considering the information provided. I think we can say that we've done that. What we must do is determine whether we think a targeted engagement is sufficient in relation to the proposed change that we've heard about today. And the choice is for us to say whether we agree with the targeted engagement that's more localised, or whether it should be a big consultation. Do we consider that it's a large enough change to have a large consultation? Councillor Welsh.
I think we've had some reassurances in this meeting with regards to the fact that you said that you would come back and keep us updated with regards to staffing. And you gave us some really good reassurances with regards to what it's going to look like with regards to parent support and having those facilities available. I personally think that if we have some reassurances today that you will keep us up to date, even if it's not necessarily coming to this meeting, but perhaps providing regular updates to, say, Martin and Councillor Sue Saddington, that then can then decimate, send it out to all of us. I think that as long as we've got those reassurances, I think, as you said, it's a matter of urgency, and this isn't something that I'd want to delay at all. It's desperately needed. The way it's been presented today has been excellent, and I think all of us that have raised concerns have said that, that the concerns have been alleviated by what they've said. So the main things for me would be the staffing and the fact that parents are well looked after when they're there. If we can get reassurances on that, then I'm personally okay with the targeted consultation.
Thank you. Thank you, Councillor Welsh. Should we just have a show of hands to be absolutely certain that everybody's happy about this? Show of hands. We're happy with the targeted. Yes? Yes? Right. It seems to be unanimous. So thank you very much, Dr. Lee, and thank you to you, Lucy. I think you're staying, Lucy.
I am, yes. And I'll just for the record as well, we will work with Health Watch to inform the engagement approach, assuming that we get the capital release, which we hope will in the new year.
And you'll keep in touch with
us. And
we
are very happy to come back. So please.
That's lovely. Thank you very much. Thank you to both of you.
Thanks.
patients that have made long queues whilst the pandemic has been at its most.
Could you ask John to just mute himself until he speaks, because we're getting a lot of background noise from...
Councillor Doddy, could you please mute yourself, because we've got some background noise.
No problem.
Lovely.
It's a pleasure.
Thank you, that's better. Thank you very much, Councillor Doddy. Right, so we're starting. Would you like to start, Joe? And then we'll pass over to the two GPs that are with us. And may I say thank you to the GPs for giving up time this morning, because I realise it's a very busy day, and while you're here, you're not seeing patients, so we won't keep you too long.
Thank you. So if I do a brief whistle stop through the paper, the brief that we've provided for you, and then we can do the handing over to the GPs and then do the questions as we would normally.
Can I just mention to the people who've joined us, we've got live YouTube, but it isn't coming from the little box through there. The gentleman is way away doing it virtually, so we have been asked to speak into the microphones to make sure that it transfers. Thank you.
Okay. So hopefully that's loud enough to transfer. So fabulous. So thank you for inviting us back again this morning, and definitely familiar faces from last time in the room. So if I start and take you through the brief that we've pulled together for you as a request following our previous visit. So to note, we are now at 124 practices across Nottingham and Nottinghamshire, and that is 37 in the south of the county and 37 up in mid-Nottinghamshire part of the county. The paper in front of you takes us through the data that was requested of us at the last committee. So looking at workforce data, and goes through the information that we were able to access on the National Workforce Reporting System. And the first appendix gives you a list of our practices across the county in their PCN catchment areas, so that you can see what staffing groups we've got. And as part of that staffing, I've listed out for you the information that we've provided for you in terms of the network, the practice, the list size, raw and weighted means adjusted for practice demographics in terms of the sex, deprivation and age of that registered population, number of GPs, whole-time equivalents, and the rate per 1,000, same again for nurses and for admin staff. And then we've provided you with a little bit of a summary in terms of how we compare against the averages. And as you can see, as we work down the numbers, we've got 37 of our practices across Nottingham and Nottinghamshire below the average. So the way that averages work, there are always some that are below, and 21 of those are in the county. When it comes to the nurse workforce, again, 52 practices across the CCG below the average, but 27 of those being in the county. And then in the administrative workforce, we have 46 practices below the average, with 29 of those being within the county. So we thought it was worth mentioning in the brief that each of the contracts and general practice contracts are businesses, as we covered in the last time, independent businesses in their own right, and they recruit their staffing complement to meet the needs and requirements of the patients that they serve. We have some established workforce groups where we look at attracting new GPs and workforce across the patch into Nottingham and Nottinghamshire, so trying to attract in those workforces as they go through training and to bring in new workforce to support our general practices. And some of that is done through training and reducing the attrition of the qualified staff by making sure that Nottingham and Nottingham's an attractive place to work, and we keep the people that we train. And we try to also encourage the flexibility of portfolio. So what we see more often now is GPs having more than one role in terms of delivering services to patients, but having that portfolio broader career. Moving on to the introduction of primary care networks. So primary care networks are a collection of general practices working together to provide services for an area. And in the brief on page 4, I've listed out our primary care networks across the mid-Nottinghamshire and South Nottinghamshire area. And as you will see, there are 6 PCNs, primary care networks in South Nottinghamshire, and 6 again in mid-Nottinghamshire. And alongside the national change in terms of introducing the national policy for the introduction of primary care networks came the introduction of additional roles staffing to complement the general practices, but they're employed to deliver services at a PCN level, but supporting the work undertaken in general practices that they're employed to provide in. And some of the examples of those workforce are the clinical pharmacists, physicians associates, OTs, etc. And then in Appendix 2, you can see a full breakdown of the current staffing complement of additional roles staff at August this year, and our PCNs continue to increase the recruitment of those numbers as we progress through the year. We were also asked to have a look at GP survey. So GP survey data is available nationally for any practice, and we've pulled out the information in terms of our GP survey results, and we've provided in the brief a summary of the CCG average, as well as the national average, and then our highest and lowest practice in Nottingham and Nottinghamshire. And we've summarised the percentages for you as part of the brief in terms of the questions, showing our delivery of how many of those are below the average again on each of those questions. Provided for you the August to August comparative in the brief, and since the paper actually came in for yourselves, we've now got September 21 data as well. So September 21 data, just to give you the latest numbers, there were 548,322 appointments delivered in September, of which 60% of those were face-to-face. So we're seeing an increase gradually over the months of a return of the increase of face-to-face appointments, and then 57% still showing as urgent same day or next day appointments. And over the page then we've sort of shown the graph outlining the journey as we've come through COVID from April 2020 to present time in terms of showing the upward trend in appointments delivered at general practice. Then just to summarise.
opinion today, because there is a situation and that does need dealing with. And I think as a health scrutiny committee, we need to find ways of supporting, as well as saying we want to see league tables and lots of data.
Joe, I don't think you necessarily need to answer that. I'll move on to Councillor Adams, please.
Thank you, Councillor Saddington. I'm glad we've finished the political broadcast by the Labour Party. We can get back to scrutinising the healthcare of Nottinghamshire. Look, there are no question there are challenges across the Shire. There are no questions, and there are no questions that there are challenges across the UK, specifically in healthcare. But I think, we are here as a committee to scrutinise Nottinghamshire's healthcare specifically, and, ask questions specifically that improve the healthcare of people in Nottinghamshire. And I think that's what we should get back to be honest. So my first question would be around data. One thing that seems to be lacking is a data feed. Now, whether that be that you've obviously just pointed out that there is a missing data connection between who's visiting GPs and under what means. So are they there to see a nurse, or are they there to see a GP? And finding that exact specific reason what they're there for, I think we need more data on. And I think how that comes about is a better way of maybe managing the way that the calls come in. I think something that's in a private business, if somebody rang a telephone line 200 times, that client would move business. They would no question in their lives, if they're in a certain telephony service or whatever, and they couldn't get through, they would transfer their business elsewhere. We're in a position here where the customers of GPs are effectively in a captive audience. And so that ability to transfer is not as simple because people have relationships with their GPs as well, which is absolutely fantastic. But is there a way that we can pull, whether it be under, let's take Arrow Health, for example, one of the ones that's listed in the report. They've got a number of surgeries across Nottinghamshire. Is there any way they can come up with some sort of proper call management system, as opposed to putting this reliance onto receptionists, which, I think, or the first person that's handling the call? Is there a way we can look at what was the average call abandonment time? What was the average time in a queue? What was the average speed of answer? Was it a first call resolution, or have we got a call coming back from that again within a week as a result of the issue not being resolved? Where can we need to understand better the flows of calls and what those calls are doing in order to be able to act on it, in my opinion. So whether it's a GP under a group like Arrow Health, what work's being put in to make that happen so we understand the data better? That's my first thing. Secondly, I would like to sort of ask, when do we foresee business as usual kicking off? When do we expect to see GPs returning back to the full face-to-face appointments? When have we put the feelers out to the GPs and asked that specific question? And I think your point about the change in social distance will definitely aid that with surgeries that are under specific size issues. But I wonder, has the communication out there? Do we know when they expect to be fully seeing patients again? And finally, my final point is around data points again in regards to the FTE. So I see within the report that we're looking at a 0.4 average FTE as a UK average, and we have some that are below that and some that are above that. But what is the actual target figure FTE per 1,000 people? What's the the unicorn? What are we aiming for? If it's not a unicorn, if it's a animal of another type I can't think of, then what is that? What is the ultimate goal? What are we aiming for? Because it's all very well looking at an average, but is the average right? I mean, is the average actually a target figure, or is it below what we should be actually requesting for as far as FTE per 1,000 people? And I think that's it. Thank you.
Thank you. Joe, do you want to answer these questions, or do you want to have it as summing up at the end? Which do you think? Because we might get similar questions. Right, so let's move on then, if you've got a note of those questions. Councillor Bailey.
Thank you very much, Councillor Saddington. So I'm quite keen on the data aspect of it as well. So in terms of the, on page 41, you've got the appointment mode and it's face-to-face, telephone, etc. I believe I read a report where it was thought that some of these appointments were being mischaracterized. So instead of a telephone appointment being lodged as telephone, it was a face-to-face one instead. I believe that was in October 2021. I think it was in the Telegraph. I'm sure you might be familiar with it. So I just wanted to get clarity on if you've been looking into that and making sure that what we're doing here in Nottinghamshire is accurate and these figures are accurate. I suppose the other point I wanted to look at was the data on page 38 to 40, where you've got the stats on how easy it is to get through to someone at your GP practice on the phone, etc., etc. I was just giving a look, and I believe the worst performing one in this respect was the Sherwood Medical Partnership, which had 21% people say it was easy to get through to someone on the phone, 7% on how often do you see or speak to your preferred GP when you would like to, 28% on how you would describe your experience of making an appointment, and 55% on how you describe your experience of your GP practice. Now, of course, these are very individualised statistics. However, as Councillor Martin suggested, some of these are better than others. And I was just wondering what collaboration is being done to work with those who seem to appear to be performing better to those who are perhaps performing under par. Because I'm looking at this 7% figure and I think that's quite awful, to be honest. Especially when you consider some of the others, which in the 69%. So I was just wondering if we could have some clarity on what's been done to improve those figures. I think that is all for me. Thank you.
Thank you, Councillor Boney. Vice Chairman.
You'll be delighted to know I'm withdrawing all my questions because I'm just desperate to hear from our GP friends who we've invited in to tell us their experiences of best practice across the region. And I'm sorry that you've sensed some political tensions in the room this morning. This is not a political committee. We are here to represent the residents of Nottinghamshire. And on both sides, Councillor Adams, I don't want this to become political at all. But at the same time, we all of us collectively do hear from our residents potholes and access to primary care. They're the things that people are most concerned about across Nottinghamshire. We've sought data, as Councillor Welsh referred to, and I actually have some empathy with what Councillor Welsh said there about the data. It is confusing. We've got more data which confuses us even more as humble councillors. And often what we find the data tells us is not a whole lot, actually, because we still can't compare practice to practice to practice to learn from, not to criticise, not to pull down, not to tear apart, but just to help. And that's really where we're coming from today. That's why we've invited you. And so I can't wait to hear. Just on a side note, Dr. Stephen Short, looking at me over there, has been my GP for many years. And Councillor Doddy, I'm sorry to tell you this, as far as I'm concerned, he is the best doctor in the whole of Nottinghamshire. And I had nothing to do with inviting him here this morning. I want to make that absolutely clear. I had said that an exemplar doctor would be Dr. Stephen Short to bring. And it's the CCG that invites you, nothing to do with me. But you're very welcome, all three of you. Thank you.
Thank you, Vice Chairman. I've got three more speakers and I agree with the Vice Chairman. We do need to speed it up so that we can hear from the GPs who've given up valuable time to be with us. So, Councillor Wilmot, can you give a quick précis of your question, please, so that we can move on?
Yeah, as I say, it's a very important decisions having to be made today because of some of the practices. The variation in practices is very serious, I would point out. Do we have any figures on how many residents try and get through to the doctor's surgery? Is there any figures on that? Because the reputation, as I say, the police's reputation is not great, but it's far better than the NHS, unfortunately, at this present time. Can I say that in my own town, Wyburn Medical Centre and Torquard, overall their services are tremendous, but I do get so many reports that they can't get a GP practice a GP on the phone, or they can't get to see their own GP and the situation. I know it's a really serious problem, and of course. The main thing is that we're a growing population, seriously growing population, and it's causing the GPs a real problem, because if you've got so many patients to deal with and they're becoming more and more and more, it's a problem that is so difficult to address. Can I say also how many patients are presenting themselves at A&E because they simply can't get a GP appointment, and what do you think that is? What sort of impact is that on our frontline NHS? Thank you very much, Chair.
Right, Councillor Gowland and then Ajanta, and I'm going to suggest, Joe, that you hold your answers back. I'm very conscious that we need to get these GPs to be able to speak and to be able to get back. Otherwise, we will have more complaints that people can't see GPs. So please, can we speed it up? Joe, you can answer after the GPs if you don't mind. Councillor Gowland.
Very quickly, first of all, I'd like to thank you enormously for this enormous amount of data. I don't know how much work it was to get it. I'd actually like to ask if we could have it on a spreadsheet so we can really dig into it. What's become clear looking at it is two things. One is that it isn't obviously the case that the doctors, the least staff, have the best outcomes. The Sherwood medical practice was picked out as one example where it's not particularly low staff. But there is, as far as I can tell, a link between the deprivation index, which I believe is the ratio of these two columns, and the outcomes. And I think we need to recognise that issues join up, that we can't take things in isolation. I am a friend of a GP. I've known her since school. I've never known anybody more positive and cheerful. And when I spoke to her in October to invite her to something, she couldn't come. She was absolutely burnt out. This is not the person I know. So we have to accept that the life, if things are under-resourced, or if there's massive deprivation in an area, the services will suffer. So I would be grateful if we could have the data so we can actually understand the details of what's going on. Thank you.
Thank you. Ajanta, do you want to ask your question now after you've heard the GPs?
Can I quickly ask my questions, please? Because one of my question is to the GPs, if that's all right. So thank you ever so much for the data. I echo the previous councillor, and excellent suggestion to be on spreadsheet. And can I quickly plug in that can I also have data on the city practices? All this is county, I don't have. So that was one. The second was I'm echoing Councillor Welsh in saying that I do acknowledge, or Health Watch acknowledges, GPs are under tremendous pressure, and there is an issue of GPs leaving. So retention and recruitment is an issue. So some information on that would be really helpful. If there is some planning in place. And I echo what Councillor Adams is talking about, the phone system and triage being an issue, that we do have a lot of anecdotal data of numerous practices where patients are holding for 30-35 minutes in the queue, and then nobody is answering, and then they are left with no appointments. From the GPs, I would really like to learn if they have any insight, or the long-term condition with the new system and with the patient-initiated follow-ups, how that is being managed, or if there is a new system on long-term conditions. So that would be really great to have some information on that. Thank you.
Thank you very much. Well, we'll put those questions just on hold, and Joe will answer them. But I do want to move on to the GPs, because I think we all recognise what a terrible time it's been for them. They have obviously taken a lot of flack for not having people in the surgery, but it'd be interesting to know how they're going to pull themselves round, how they're going to have face-to-face surgeries if they're not already doing them, because we all appreciate they've been under pressure. Can I ask that in your brief you give us some idea of face-to-face with your medical staff and face-to-face with your nurses who do relatively everyday things that people can see a nurse for, and how you will be tackling this regarding appointments, which several people have referred to, how you will be able to establish appointments within your surgery, and how much you will be moving over to virtual, because there must be a reason where people want a prescription, and how can you hurry that up? Prescriptions, particularly where people are holding up a line to order a prescription. Can it be done by email? Can it, if it's a repeat prescription? What ways can you look at to try and speed up access to your surgery? So, Dr. Stott, I'm going to start with you, and perhaps you can give us a brief on your surgery.
Thank you very much. Can I start by making a couple of observations? I don't want to adopt the mantle of victimhood or make people feel sorry for general practitioners. General practice is a joy. Most of my professional colleagues regard it as a joy and are in no sense feeling victims. And yet, of course, we have had 18 months of unprecedented pressures which have taken their toll. So the real victims of this pandemic have been those who've experienced loss, including bereavement. So I wouldn't want to try and suggest that actually that my experience is actually worse than theirs. The second thing I'd say actually is that patients' behaviour through the pandemic has been extraordinarily supportive, absolutely exceptionally supportive. And again, I don't say this in a paternalistic or patronising way, but it's simply true. Patients have behaved beautifully, they've behaved respectfully, they've behaved reasonably, and actually it has been a hallmark. Actually, from the start of the pandemic to current times, the professional-patient relationship has been really strong and effective, and yet it's starting to degrade, I think, at the present time through the longevity of the pandemic situation and conditions and the frustrations which are now coming to the fore. Third thing to say is actually that we shouldn't forget, as you said, actually, and it's not party political, but it's simply true, that actually even before the COVID pandemic arose, general practice was facing pressures of increasing demand and the increasing mismatch between demand and available supply. So we're already dealing with a system which was actually struggling. GPs are struggling with bulging lists, contacts were too short and over full. There's heightened complexity, more and more people living with long-term conditions, and more and more people living with multiple long-term conditions. So the burden on general practice was great to start with, and it's been amplified, and its weaknesses have been amplified by the COVID conditions. And it's not through a lack of care or attention or insight, but the sheer difficulty of the task at hand. I have to say that currently the state of general practice is that it is distressed and it is struggling, as many other parts of society are distressed and struggling. Again, no special pleading, but it's simply true. Colleagues have found the last 18 months very difficult indeed, and actually there is much stress, burnout, and there's much talk of the unsustainability of the workload, and that is leading to colleagues deciding to consider their work-life balance and whether they remain in practice or not. And clearly that's something which we need to address greatly. We started off with great, 18 months ago, we started off with great spirit, commitment, determination, the kind of we shall overcome mentality, and it was for a long time, actually it was a very positive experience. Patients received transformed services by the telephone, by video consultation, by other means of digital consultations. General practices started to network together with other local practices to ensure resilience and sufficient capacity. They started to look out. One practice would look out for another practice in terms of its risk around the almost daily experience of a doctor or a nurse or a healthcare assistant or a member of staff from reception having to take immediate time off, even being pinged by test and trace during the morning. And a number of my rooms, there's the last one out before the door, and literally I saw GPs leaving the building during morning surgery because they've just been pinged by test and trace. And there hasn't been a week gone by where there hasn't been significant absence through either having COVID or waiting for tests to tell you you've had COVID, or looking after children or the people for whom our staff care who might have COVID and who are isolating. So there hasn't been a week gone by where that hasn't been a genuinely important experience. And of course, general practice is a small scale. We are small businesses. We don't have the resilience of a big hospital. We don't have the economies of scale that a big hospital have. And actually, funding over the years has favoured investment in hospitals rather than general practice. So general practice is fundamentally vulnerable, and the pandemic has revealed that. On a positive side, we have during the pandemic created these new entities called primary care networks, which are groups of locality-based groups of general practitioners and general practices who are working increasingly within their own building and across their buildings together in a networked fashion to offer greater capacity, greater resilience, and greater responsiveness. Amongst some of the things that some of these PCNs are doing is to develop telephony capability to answer exactly the questions, that business intelligence that you need to run a business. Frankly, you can't do it without having that data. And so some practices, some of the very large practices already have that functionality on now. The one just around the corner on Wilford Lane has that functionality. It can tell you call abandonment rates and how long times and median times, and it can interrogate it, and we can know that in great detail. But that's uncommon. But more and more practices are looking at trying to get that functionality, and when coming together through the PCNs, they're also again looking to invest in that functionality so that they can actually have a great insight into what's going on. Because you're absolutely right. I can say that if a patient rang my surgery this morning and wanted to speak to me today, they will. They will. And if that patient wants to see me face to face, they will. They just will. Having said that, though, what I can't tell you about is the numbers of patients who are trying to phone the surgery who don't get through. I have no knowledge of them. And again, I hear that on a daily basis, that they report to me that actually it took 45 minutes. I was 17th on the queue, then I was 19th on the queue. And it took me 45 minutes. And it's deeply embarrassing. It's deeply unsatisfactory. And again, we do need to start to understand the undeclared demand, which hasn't been declared because actually practices haven't been able to practice telephony systems haven't been able to identify those patients. But broadly, the model which pertains today, because of the need to manage flow through the building, to manage social distancing in buildings which are not designed for such a facility, has been that general practitioners will call back a patient on request, and between the GP and the patient, there'll be a negotiation around what the best outcome might be. And often it's possible to deal with something over the telephone, particularly if the patient's well known to me, with a problem which is well known between the two of us. I can often do things like sick notes, medication requests, medication reviews on the telephone. Similarly, patients do get a call back on either a video call or a call on their work or mobile devices, and at their convenience that same morning. And again, that works tremendously well for lots and lots of patients. It doesn't work well for every patient, and it doesn't work particularly well for the patients who are perhaps elderly, frailer, with multiple long-term conditions, and who have a different way of expressing their needs and voice. I think so there is an initial triage undertaken between the doctor and the patient. There is a negotiation then about what the best outcome might be. I don't know every single doctor who says no. If a patient says, "Do you mind?" I have patients all the time say, "Do you know what? I'd really like to see you." I don't know that any patient. I mean, there probably are doctors who said no, but I don't know. I don't know who they are, because all the colleagues that I'm aware of are pulling out all the stops to see patients in that way, if that's desirable. And do you know what? For GPs, we miss that more than anybody. More than anybody, we miss that almost as much as patients do. It is dismal to speak with somebody on the phone at 60 times a day. It is utterly dismal. To see patients face to face, to re-engage with patients, to re-establish relationships face to face is part of the joy of going to do the job each day. And increasingly, I say that we are doing more and more face-to-face work. I've done half a surgery this morning. Got another half surgery when I get back for afternoon surgery this afternoon. Today, I will encounter probably about 50 patients, and probably half will be face-to-face. So it's starting, but it will only be completed when the IPC, infection prevention and control mechanisms, are liberalised and such that we can actually increase the distance, reduce social distancing, operate without PPE, operate without masks, operate without the need to triage patients before they come into the building to make sure they don't bring their COVID or their respiratory viruses into the building, which can cause the absolute consternation that causes, and it just brings the whole practice to a standstill if someone is proved test positive. So I'll perhaps just pause there and let people come back to me on any specific areas of that reflection. But I wonder whether, in fact, that gave you a sense of what it's like to be a GP at the present time, and how things might change in the weeks to come.
Thank you very much. In a moment, I'm going to move to Dr. Doddy, who's waiting. I'd just like to make one point. I think what has happened, there seems to be a policy that you ring at 8 o'clock in the morning. Everybody has their fingers on the button for 8 o'clock in the morning when the doctor's surgery opens. And if you're 20 down the line or whatever, then there are no more appointments that day.
Yeah.
Now, one thing, we changed from a surgery where I live into what is a very good surgery now, a new surgery that we moved to. And I have noticed over the last week, and it's the first time I've ever noticed it, and that's because my grandson has been quite ill, and we've had to constantly get back to the GP, who I must say has been superb. But what I've realised is that these people who ring up at 8 o'clock in the hope of getting an appointment that day, and by probably 10 past, 8:15, all the appointments have gone. What my daughter has found is that if she's had a crisis with my grandson through the day, which we most certainly have, she has rung the doctor, and we haven't been told all the appointments have gone. We've been told the doctor will get back to you. And that isn't happening. And as a result, I think people are automatically going to the hospital then, because they feel they've got to wait until tomorrow morning for an appointment. But I've found through our surgery that we've had return calls, albeit all the appointments must have gone. But there must be that little bit of spare capacity. And I think that's very useful. And it certainly has been in our case.
May I reply?
Yes, please do.
I know John wants to say something as well. But, so yes, I think we need to be. I think if we were better at explaining the nature of our service and how it's configured and how it's set up and how it's best navigated, we do. People might feel more confident that there is an appropriate service to meet their needs as and when they need it. Yeah, at 8 o'clock. There will be on any doctor's list a number of appointments which are released at that moment or which haven't been used in the days before, which are made available for patients to use on that day. And they will probably be a limited number, and they will go quickly. Having said that, though, that's not the end of the story, because actually yesterday I was the on-call doctor. So anybody after all those appointments had been taken up, any patient who declared themselves to be in need of speaking to a doctor yesterday was put on the extras list. That was my list, and I phoned every single one of them. So just because the appointments have gone with a bookable appointment has gone with a named doctor, doesn't mean to say that's you've lost your opportunity to be seen that day. Contractually, I'm obliged to meet all my patients' needs up till 6:30 at night. So I'm obliged. If a patient says to me, I have an urgent care need, I'm obliged contractually to respond to it. And I can't respond to it unless I've spoken to the patient and assessed that need and made a decision about what that patient's, what's in the patient's best interest in terms of a response. So you're absolutely right. The limited numbers of bookable appointments which are currently available because of COVID and in any case because of external demands and pressures will go very quickly. But throughout the day, for the rest of from 8 o'clock till 6:30, there is access to care and to assessment throughout the day.
That's really a good point to mention, because I really don't think it happens everywhere. And that's why we're getting so many letters to say, I can't get an appointment. I've got to ring again tomorrow morning. Well, and I think this is one of the chief things that we need to be looking at, because you can't all ring at 8 o'clock. Some people are at work, but to be able to get an appointment later in the day has been for us an absolute saving grace. And I think for other people too, it would be. So
again, without wanting to hog the floor, but
I'm going to Dr. Doddy in a minute.
I've got the lights on, so I'm keeping it on. There is a difference between having an appointment with a doctor of your choosing, which you booked in advance, of which there are limited numbers currently, and then a consultation with Dr. Doddy, because actually you've declared a need at 11:15 on a Tuesday morning, and Dr. Doddy decided actually he needed to see you. There's still appointments, there's still contacts, there's still consultations.
That's very interesting to know. Thank you for that clarification. So, Dr. Doddy, we're coming to you, Chairman of Health and Wellbeing at Nottinghamshire County Council. Can you hear us?
I can hear you. I can hear you. Can you hear me?
Yes, we can hear you. But
fantastic.
We have to speak into the microphones because the YouTube is not going out from this room. It's going out from somewhere else. So we are asking people to speak up, if you wouldn't mind. Go ahead with all your brief, please. Welcome.
Fantastic. Were you asking me to speak up there, or were you addressing the room?
Pardon?
Were you asking me to speak up because you couldn't hear me, or is it?
No. Everybody has been reminded, not just you.
Oh, fantastic. I was just. I was in great humour earlier on till Dr. Short sort of started off. And for a man who said that they were in great form in general practice, halfway through I was getting pretty depressed, but he picked it up towards the end. So I was left with a feeling of optimism. I mean, it was Robert Louis Stevenson that said books are a mighty bloodless substitute for life. And I can honestly say that telephone and remote consultation is a mighty bloodless substitute for face-to-face consultations. We have to remember when we're looking at all this that general practice looks after 90% of the entire consultation and workload of the NHS, and only 10% goes into secondary care. We are the gatekeepers. We do it for less than 10% of the entire budget of the NHS. We are the best, most economical service that's existed in the history of mankind. And that's what's made general practice the success and the envy of the world for many, 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 many years. And our task really, as we look forward, and as Dr. Short has pointed out, is to try and maintain that, to try and save it, and to try and continue to put forward that idea. I'm here, again, like Dr. Short was earlier on, at the coal face of general practice, and the phones never stop ringing. I'm going to try and focus on a couple of things that I see as positivities, things that I see as important when I deliver care from Hickings Lane Medical Centre. And I think in the last patient survey, we were 5th out of 124 practices for patient satisfaction. I'm going to say, how do we deal with the challenges of patient access? And I'm going to show you a little video with the help of technology here. I'm going to see if I can go to a share screen. So I'm going to just try and do that now. Let me go to this one. And am I able to do that? Let me see.
You're speaking, John, but we can't hear you. On the video, I mean.
You can't hear on the video. Do you want to just do?
We can now see you in the surgery.
Yeah, we're working on this. Is technology. It takes a bit of time. Hold on now. Yeah. Yeah, go. No, you can't. You're okay. Go ahead.
Hello, my name is Dr. John Doddy, GP at Hickings Lane Medical Centre, and this is our waiting room.
Yeah, just.
Our waiting room will be buzzing with the traditional feel of a normal general practice, with people coming and going as it was pre-COVID. Nothing can beat that traditional face-to-face consultation where the GP and the patient are sat together. It's such a fantastic opportunity to pick up things that you may not even have come in with, to check a blood pressure, to check a weight, to pick up undiagnosed diabetes, to see a mole that's changed but you hadn't paid any attention to it. This is the bedrock of good general practice, and it's coming back to Hickings Lane Medical Centre. Every day, at least one GP will be available for face-to-face consultations. That's not to say that some people will not prefer a telephone call, a video consultation, an email, a text. Those will still be available. But our message to you is welcome back to traditional general practice. Come in and see us.
Well done, John. That was lovely. We'll all come.
Yes, I'm hopefully back in the room again. That's as part of what I'm sort of trying to get across to people today, that we can look at national issues with general practice recruiting, etc., but we can't necessarily change that locally at the present moment. The fact that when the King's Fund asked GP trainees how many of you were going to work full-time, and 1 in 20 of them said they would work full-time, 5%, less than 5 out of 100. The challenge going forward nationally is a huge challenge, but locally, in terms of practicality, Hickings Lane Medical Centre has 37% uptake of the NHS app, the -- 1 practice for NHS app use in the entirety of Nottinghamshire. We started early, we got people signed up, we brought out the app company themselves to sit in our waiting room to sign people up. Now you may say, what's the benefit of that? That means you can go online and you can go on the app and you can order all your repeat medicines and your repeat prescriptions. What is the benefit of that? The phone doesn't ring in the surgery all day, every day, because people are using the technology that exists to access the services. We have to use the facilities that we've got locally in order to improve a local problem. So NHS app, it's out there. We should be working with more of the practices to help them access the technology. And as Stephen says, there are some really good practices with really good up-to-date data. But we should be helping the other practices to do that. I think in terms of that video, that was one of numerous videos that I put out over COVID, telling people to come and get their vaccinations. Some of them had maybe 6,000 views, but I've only got 6,000 patients, etc. So you were getting through to practically everybody, inviting them in, telling them how safe it was. Good communication from practices remains the bedrock of actually providing that service to patients. Uncertainty, lack of knowledge, inability to know that your practice wants you to come in is the absolute key. So removing the barriers post-COVID was very, very, very important. And actually, as we move forward with the transition of general practice through the integrated care services, through the place-based programmes, through the primary care networks, practices are becoming part of the community. They are looking outside themselves, looking outside their practices and becoming the bedrock of the locality. And that's what we're trying to do, to give back that confidence, to bring the patients back in. And we've had tremendous success. Since I've done that, I've done no telephone triage. I do 100% face-to-face consultation. I'm not saying it's not easy, but it's a sheer pleasure. If you telephone somebody and they've got a sick baby, you can't feel the tone of that baby as to whether it would slip through your arms because it's got some sepsis or it's got some neurological problem. When you speak to people with a bad back and you see them in the surgery, they can walk into you with a limp and you know the problem isn't in their back, you know that they've got a bad knee. You never ever pick up anything opportunistically in your whole life by making a telephone call. So there is no doubt that that is an area that we're actually aiming to get back to, and we should be aiming to get back towards the 80%, and God willing we'll get there in due course. A couple of the things that I would like to point out is that there's no mention in this of estates. We've got a huge number of ancillary people starting to work in general practice now. We've got the physiotherapist, we've got the social prescriber, we've got the physiotherapist, we've got the pharmacist, etc. But what we haven't necessarily got is the estates and actually the ability to house these people in general practice. So we're getting more and more people, and then they're scraping around looking for rooms. I would like our ability and facilities to provide the care for the people of Nottinghamshire has got to be embedded in the actual facilities and the estates to do that. We haven't looked at the other big question, which if 1 in 20 GPs been trained only wants to work part-time, where is the succession? Where is the movement from the single practices, the smaller practices and the bigger practices towards a genuine succession plan for the people of Nottingham? Should we be going more towards federation? In the time of COVID, all the practices that were local rung each other and said, if you go down, we'll help you. That has now gone back to people looking after themselves. I'm hoping the primary care networks will be the focus of a move towards more federation, where all of the practices get together with shared responsibility. This can no longer be delivered by a series of small or medium-sized practices working independently, scattered around Nottinghamshire with varied outcomes, from people who are satisfied 7% to people who are satisfied 100%. So I think we're in a tremendous challenge at the moment. We're succeeding because we speak to the patients, because we communicate with the patients, that we find it a joy and a pleasure to work with those patients. And I think that the possibilities of improving care around Nottinghamshire lie in the things that we can achieve rather than the things that we can't achieve. But be under no illusion, as Stephen Shaw pointed out, seeing patients face to face is actually an honour and a privilege, and it makes our lives better. So I'm going to throw that back into the room and say, let us think about what we can do today, tomorrow, to improve care in Nottinghamshire, and then let the government deal with the bigger problems. Back to you, Chairman.
Thank you, John. Thank you very much. I'm hoping that over the period of time that we have a few more GPs to connect into us, that we're going to be able to pick up ideas and probably put it towards some recommendations for improvement throughout Nottinghamshire. I think both of you who've spoken have given us some ideas, and thank you very much. Now, Dr. Trimble, would you like to come back and, well, you haven't spoken yet, but would you like to partake in a brief?
Yes, I'm not currently a practicing GP. I retired. I left practice some years ago, but I could answer some of the earlier questions that were put to the floor.
I think Joe would appreciate that.
This is a bit drier than the two responses that you've previously heard, I'm afraid. But I would echo the comments made by my colleagues. There are actually increasing numbers of practices across Nottinghamshire and in Nottingham City that since we last met, in fact, are opening their doors and are actually seeing more patients face-to-face and are allowing direct booking of face-to-face appointments. So things are certainly moving in the right direction. To answer the question about the accuracy and granularity of the data that your colleagues have asked, this is dependent on extraction from the GP systems. We did touch on this at our last meeting, and we are, I'm afraid, quite dependent on national returns and reporting for being able to access that data. So I'm afraid we simply do not have that at the moment. A point was made about telephony. During the pandemic, practices have become highly dependent on their telephone systems, and old traditional systems have limited lines. And if you have limited lines, it means that people can't get in. So people are sitting on the lines making outbound calls. You can't get in. What's happening about it is increasingly practices, Stephen mentioned one locally, implementing more advanced cloud telephony systems which overcome the line limit and improve accessibility, both incoming for the patients and outgoing for consultations. As part of the Winter Access Initiative, a national initiative, there is, as part of that, a cloud telephony initiative. We will be required to work with practices to offer the facility of cloud telephony, which will hopefully improve things. That's not to say everyone will take it up, but the offer will be there. A number of you made a point about a variation between practices. Dr. Loddy and Dr. Short talked about practices coming to work together, working collegiately in primary care networks. That is certainly improving quality across the piece. The other thing that the CCG is doing is it is quite aware of the variation. You did mention some individual practices. I won't return to those named, but I would say that we are working with those practices directly that have reported poor feedback, and are working with them to improve outcomes. Estates is a perennial issue. John mentioned there, it's a perennial issue. The CCG again has an estate strategy, but once again, resources are a significant issue around developing increased estates capacity. My final point would be around the other key element of capacity, which is workforce. That is recognised, has been recognised for a number of years, and there is the CCG not only has a strategy, but it has a whole team working on trying to address the workforce situation, particularly with regard to recruitment and especially retention of our clinician workforce. I hope that's answered a few of the questions that were put to the floor.
Thank you very much. Thank you. Now, Joe, I'm going to move on to you, ever conscious of the time. If you could give us a quick sum up. I know we'll be seeing you again, and I'm sure we'll be asking you to come back. This is a huge subject for every member in this room at the moment, and so we won't be saying goodbye to you today.
Yeah,
thank you, Joe.
Thank you. So Ian quite quickly ran round a lot of the questions that you've put to the floor as we've gone through, and I think most of them are answered actually. I was just going to pick up further on the estates point that Dr. Doddy mentioned in terms of those additional staff. There is about to be a kick-off of an estates toolkit. So nationally, they've issued an estates toolkit which supports the review of each of our practices and gives us a priority list depending on IMD deprivation type statistics. So that's only recently landed with us at the CCG from the national team, but that should start to pick up some of those space utilisation challenges that we're experiencing across our practices. So thought it would be good to mention that. Absolutely, in terms of the point Dr. Trimble made around some of the specific practices, we are absolutely working with them. Where we've had some mentions of practices today. I think it's also worth mentioning that a couple of those practices have also already installed new phone systems to try and make that access better. And I think that is pretty much it, apart from to say, yes, we can put it into spreadsheets for you. We have got the data behind the PDFs in spreadsheets, and Adianti, yes, I have got for the city.
Thank you, Joe. I'm getting indications from Councillor Adams that he needs a very quick word, and I mouthed to him very quickly. Oh, Dr. Shaw. So,
Just very small, just a couple of things on the telephony, because it's just sort of occurred to me. One of the other things that you advance in having a form of telephony system that is centrally controlled, you can spot spikes, obviously, in call volumes, and whether that, I don't know, that help outbreak stats or anything like that, or help you determine things that are kicking off in certain areas. In the likes of COVID, it would have maybe helped detect certain spikes in maybe what's happening in areas for detection. So just something else where you can use the data to positively influence. And just on the cloud telephony aspect, is that something that is, did you say that was coming funded from, is that a sort of funded project or?
We don't have full clarity. The announcement was that nationally they are looking to procure cloud telephony for primary care. The detail behind that is that we believe that they're looking at software solutions rather than implementing whole solutions, and it becomes complicated because some practices have invested their own money in this, and we're not clear how much of the national offer will recompense them and how much is for new systems and who will pay for the hardware. So there's a lot of work still to do, but just to say that that's something that we will be looking at.
Thank you. Dr. Short, you want to?
Thank you. Can I just say thank you for the tenor and tone of the debate this morning. The discussion has been really positive, and I welcome the contributions and observations made by colleagues around the room. I would say that finally, and again, without being falsely optimistic or upbeat, but actually wanting to be optimistic and upbeat, the CCG is clearly transforming to the ICS from next year. I've met with the chairwoman of the ICS, Dr. Kathy McLean. Catherine McLean, who is a former geriatrician herself, wants our ICS, Nottingham's ICS, to be stand out in the provision of primary care services and stand out in the provision of general practice services. So she's charged us with thinking about how to approach, how to set about that, how to look at where best practice is and what it looks like, where we are currently and what the gap from where we are to where we might get to be looks like, and to create a strategy to move us to stand out and best in class. So I think that's maybe something you should invite us back to in a year or so and say how are you getting on with that task.
Thank you very much. I think we'll draw it to a close at this point. It's left me to thank Joe, to thank Dr. Stott, to thank Dr. Short, Dr. Trimble, and Dr. Doddy, who have certainly given us some thoughts which we can consider during the time that we're looking at GPs. It isn't the end today. We shall return and we shall continue to look at it, and we shall borrow, if you don't mind, some of your ideas to put together when we come to our recommendations. It's been wonderful to speak to you. I do appreciate that you've taken yourselves away from your patients, and now we'll let you go at 1:45 so that you've got time to see some more today. Thank you very much indeed. Thank you so much. Bye-bye. We'll see you after Christmas, I'm sure. Happy Christmas to all. I'm just mindful of the time, members, and we have our visitor here now.
So if you hit it again when you've concluded speaking.
Good afternoon, Rebecca. Welcome to County Hall, and my apologies. I'm sure you've been waiting outside for a very long time. My apologies. We are running late, so we're having to speed ourselves up a little bit. So would you like to give us a briefing on this, please? Rebecca is the Nottingham and Nottinghamshire Integrated Care System Programme Director. That's a mouthful in itself. So welcome.
It is indeed. Thank you very much, and thank you everybody for your time today. I've just got a few slides just to summarise what I've put in the paper about the Health and Care Bill. So if it's all right, I'll just talk you through those to start with.
Can I ask you to pull your microphone close to your mouth, because we are live. Yes, we are live streaming, but we're doing it virtually, so everybody needs to speak into the microphone. Thank you so much.
Okay, thank you. So we all know that health and care systems need to continually develop and evolve if they're going to remain fit for purpose for the people that we serve. National policies now focused on integrated care systems as being the best thing to achieving better population health and well-being, quality of care, but also sustainable use of resources as well. Now, integrated care isn't new locally. We've been trying to do this for a number of years, really trying to develop across local authorities and the NHS, person-centred, joined-up, seamless care. But sometimes some of the organisational barriers, different financial regimes and that have got in our way. So the Health and Care Bill is trying to help to remove some of those barriers for us, and in particular take some of the learning of how we've all worked together during COVID-19 and the response that we all were able to deliver to local people during that time. If we could go on to the next slide, please, Martin. So the Health and Care Bill sets out two new ways of working. The first one's termed an integrated care partnership, which really is around integration between local authorities and the NHS. So the integrated care partnership is a partnership. It's not going to be a corporate body if the bill goes through Parliament. The integrated care partnership in legislation will have one main area of responsibility, and that's to develop an overarching strategy for health and social care for local people. We might want to have more duties and functions for our integrated care partnership locally. Nationally, there's just going to be one requirement, and that's for us to develop an overarching strategy, a framework for integrated care for Nottingham and Nottinghamshire. The legislation will set out that the main people that will be responsible for that strategy will be the two local authorities, Nottinghamshire County Council, Nottingham City Council, and the local NHS. But obviously, locally, we would want to involve more people in that, particularly local people, community and voluntary sector, Health Watch, and that as well. But in legislation, it will say that those people have got that duty to develop that integrated care strategy. The integrated care partnership will take the form of a joint committee between the local authorities and the NHS. And as I've said, it should engage that whole range of other key stakeholders in setting out what that strategy looks like, what services should look like, what best practice should look like for local people in our area. The other element of the bill relates to something called an NHS Integrated Care Board, and it will replace the CCG. The CCGs going forward, I'll come on to this in a moment, but one of the requirements of the bill will be that NHS Integrated Care Board that will commission NHS services for local people going forward will need to pay due regard to the integrated care strategy. So commissioning for the NHS will need to be in keeping with that integrated care strategy. Next slide, please, Martin. So locally, we've got a small group that is working on what does our integrated care partnership look like. Melanie Brooks is the senior responsible officer from the County Council that's leading this work for us. Dr. or Councillor John Doddy is a member of the small working group. We've got counterparts and colleagues from City Council, Councillor Adele Williams and one of the officers, and two key officers from the NHS. Stephen Short's just mentioned Cathy McLean, who will be the chair of the new Integrated Care Board. She's working with Melanie and Councillor Doddy on this proposals, together with Amanda Sullivan as well. And those colleagues have been engaging with a whole range of partners locally to think about how do we really make sure that this integrated care partnership adds value locally. And the feeling is that there is a real opportunity here to develop a partnership that really supports shared purpose locally, that really make sure that the joint strategic needs assessments, that the health and wellbeing strategies are put front and central to all of the work that we do for local people in the NHS and social care within Nottingham and Nottinghamshire, that actually we can really support more accountability to the local population through this integrated care partnership, because it will not only want to develop in that strategy, but being very transparent about the extent to which we are implementing it and delivering best practice care going forward. And that actually there's an opportunity through this integrated care partnership to think a bit more about social and corporate responsibility collectively as well, as part, for example, of being anchor organisations. One of the things that we are working through, we haven't got all of these answers yet, is how it works, and it complements the work of the current health and wellbeing boards. They will continue, they don't change in legislation, so this needs to complement them. It shouldn't be duplicating the work of those two boards. Sorry, did you have your hand? Next slide, please, Martin. So this is one of Melanie's slides, and just some of the current thinking, as I said, as to how that this integrated care partnership can potentially drive the local health and wellbeing strategies. So as I said, the health and wellbeing boards will continue. They will continue to oversee and to approve JSNA refresh and updates and health and wellbeing strategies. And then the integrated care partnership will take due regard to those, synthesise those across the whole of Nottingham, Nottinghamshire, working with local people, with health and care professionals to develop that overarching strategy. And then that will be form the basis for the commissioning and delivery of services locally. Thank you, Martin. Next slide, please. So the transition path for our integrated care partnership in Nottingham, Nottinghamshire, as I've said, it's going to have one national function in that strategy, but we might want further functions going forward. So we need to be agreeing what the scope is, the operating arrangements. We need to have this up and running, that joint committee up and running by April of 2022 if the bill goes through Parliament. The JSNAs and health and wellbeing strategies locally are being refreshed. So once they've been refreshed, that new partnership can take those into account. And we need to be developing that first integrated care strategy by September of next year. And part of that will be really thinking about how we build on current mechanisms, for example, around patient and public and community engagement in developing that strategy. We can move on to the next slide, please. The second aspect of the bill relates, as I said, to the NHS Integrated Care Board, which will replace the NHS clinical commissioning groups going forward. So from April 2022, we will have a Nottingham and Nottinghamshire Integrated Care Board. It will be responsible for the overarching leadership of the NHS going forward and the commissioning of NHS services. It will take on the responsibilities of the current CCGs, but it will also take on potentially some of the commissioning that is currently undertaken by NHS England at the moment. So, for example, around pharmacy, optometry and dentistry as well. So be able to join up some of that commissioning for local people as well. I've listed some of the things there, and they're in the paper that the Integrated Care Board will be doing going forward. This will be a corporate body. It will have a small number of non-executives and executives that will be accountable for the work of that Integrated Care Board. And importantly, which is a little bit different from the CCGs now, it will have members from local authorities. There will be a member from the County Council and the City Council that will become part of that board. And there'll also be a GP who will be a member of that board. And in addition, an NHS provider will be a member of that board as well. So it's trying to be more inclusive and really have that whole range of perspectives to that NHS body going forward. There'll also be a number of advisors we're proposing locally, which will most likely include public health as well, to really ensure that the work is joined up with other parts of the system. If we can go to the next slide, please. There are a number of other additional measures in the Health and Care Bill. There will be a duty to collaborate for all NHS organisations and local authorities. You'd hope everybody would already do that, but that will be strengthened through legislation. Obviously, we have a number of places like Bassett Law that people recognise, relate to, where services are developed and delivered on a day-to-day basis. There isn't going to be anything in the legislation specific to place other than the fact that there is a requirement for everybody to work together to support the development of places, and obviously recognising that they need to be sensitive to local population needs, and what's right in one place might not be right in another place. One of the policy changes that we've already had is that Bassett Law, obviously it's already part of the County Council's footprint, but it hasn't been part of the Nottingham and Nottinghamshire Integrated Care System footprint to date. From April 2022, that does become part of our integrated care system going forward. So we're already working with Bassett Law colleagues to ensure that the arrangements that we're putting in place meets the needs of all of our population, including Bassett Law residents, as we move forward. Patient flows, clinical relationships will stay the same as now, but we need to make sure from a planning and a commissioning perspective that we're taking the Bassett Law population now into account as well. And just to say as well, just to highlight that the NHS Integrated Care Board will take on the responsibilities and the duties to the Health and Scrutiny Committees going forward that the CCGs have currently had. Next slide, please, Martin. We've had some national guidance on how people and communities should be involved in the development and the delivery of the Integrated Care Partnership and the Integrated Care Board going forward. What we want to do is to really make sure that we don't only meet the requirements of national recommendations, but that we go further in Nottingham and Nottinghamshire, really building on some of the good work that Alex Ball and colleagues are leading in this area. And make sure that really we become a beacon on people and community engagement and involvement in the development and delivery of our NHS and wider services. The work that Alex and colleagues is doing, Alex Ball and colleagues are doing are around a framework around 5 different areas that we've set out on this slide: governance and structures, embedding community engagement, and the other areas listed here. There's been a number of workshops to really look at in each of these areas, how are we working with and involving and engaging people now, and how can we improve on this and go further going forward. And those workshops have been held with local people, with Health Watch, with community and voluntary sector, with local authority colleagues. And there are a range of plans that are coming out how we can potentially really strengthen some of the current community engagement work and citizen involvement work that we currently do, so that services going forward really are meaningful for local people. And we've just given a few of the practical examples here. So one of the recommendations is that integrated care partnership at each and every meeting, it really does have citizen insights front and central when it's working on the development of the strategy and that really does include representation, those insights from representatives of all of our communities. So we're really making sure that the strategy is reflective of everybody that we serve. Just giving a couple more examples here, we've just got some funding as well to really look at a citizens panel going forward and how that can help to generate some of those new insights. Final slide, please, Martin. So opportunities for local citizens. So already across Nottingham and Nottinghamshire, we are trying to work to make sure that each and every citizen enjoys their best possible health and well-being. The ICS going forward should help to create the conditions for success, to make sure that we're all working collectively together, maximising the use of our resources. Today, we haven't been fully configured in order to be able to do that. This legislation, these reforms do help and aim to enable us to go further along this path. Some of these reforms are quite structural in nature. Obviously, those alone won't be sufficient. We need to continue to build on relationships and trusting ways of working together going forward, and in particular, some of the work that we've done on COVID and how we've responded to that collectively. Thank you.
Wow, that was a big subject in a very few minutes, Rebecca, and certainly takes some time to get it understand this new bill, which I have been having conversations with Melanie over. Can I ask, please, as chairman of this committee, what does the Health and Care Bill mean for the operation of health scrutiny? will there be fundamental differences? And is it anticipated that the committee will retain the power to make recommendations and referrals to the Secretary of State, or will it be a case of someone within the health service marking their own homework?
So the health scrutiny will continue as now, and the Integrated Care Board will take over some of the responsibilities that the CCG have had to date.
So in other words, the Health Scrutiny Committee will stay, but instead of having the CCG, we will be in touch with the Integrated Care Service Board. Yeah. Fine. I think the Vice Chairman wants to ask something.
Yeah, sorry, I'm still a little confused. So there'll be a health scrutiny role for both the city and the county, or will it be merged? How do you envisage that, with being the ICB itself made up of the city and county representatives? And also, how will you keep politics out of that equation?
So the bill isn't making any recommendations to changes to the city and the county health scrutiny committees. The Integrated Care Partnership will be working at a Nottingham and Nottinghamshire basis. There'll still be the two health and wellbeing boards, and the new NHS Commissioner, the Integrated Care Board, will work across the whole of Nottingham and Nottinghamshire as well. We've currently got two CCGs now. We've got one that covers Nottingham and Nottinghamshire with the exception of Bassett Law, but obviously going forward, the Bassett Law and the Nottingham and Nottinghamshire CCG will come together from April of next year. I think in relation to the Integrated Care Partnership, that will have representatives of elected members as well as officers. And I think what we see is that actually helps to improve local accountability, democratic accountability to the local population. I think sometimes there's a feeling that the NHS isn't as locally accountable to local politicians. So the Integrated Care Partnership will have local elected members as well as officers, working very much with local citizens and community and voluntary sector, and that to really work out what the overarching strategy and framework is for services locally.
So more or less we sit as we are now.
Yes.
Right, thank you. Councillor Martin.
Yeah, thank you, Chair. Yeah, there's been a lot of work behind this, and it's been going on for quite some time, about 5 or 6 years now, I think. Am I right in thinking that we will still keep the Care Quality Commission as an outside body? I mean, I know you're going to absorb the CCG into the process. The cross-border stuff. So Bassett Law obviously interacts a lot because NHS planning areas are different to county geographics. So I just want you to explain how that's going to work, because a lot of our patients travel out to sort of like Derby, Chesterfield, Leicester, you know, and up further north, Sheffield, Doncaster and that kind of thing. So, and does this mean that there will be enhanced communications between the primary care networks, the hospitals and the social service, adult social services? Because that's really where we're trying to nip it in the bud, because it's just an expanding budget into ongoing. And I think if we can get over that issue, because that seems to have been the issue in the past, getting the NHS to deal with outside other corporations, the communications, the way in which they do it is been a complicated issue because of GDP.
So the Care Quality Commission will stay. There's no changes in the bill to the Care Quality Commission, so that will continue to have that role in inspecting the quality of services. So the Care Quality Commission will stay. In relation to patient pathways, clinical relationships, professional relationships, they will continue as now. You know, the real aim of integrated care really is to try to give professionals the space, the opportunity to work together in the interests of the people that we're looking after, and to try to break down some of those organisational barriers. And we're never going to have an absolutely perfect fit with some of the structures, because you know, what some services need to be delivered on a very local basis, some need to be delivered on more of a specialist basis, on a bigger footprint. So some of those some of that working at a locality and a neighbourhood level hopefully will continue to be supported and enhanced through these new arrangements, but also some of those on a wider scale as well. Some of the opportunities there, hopefully we'll be able to capitalise on those as well. As I say, these new the legislation, the new bill, the proposals have really come about based on some of the learning from COVID-19 and how we all work together there at all the different levels of the system and across the country. And a lot of this has been by way of feedback from that time. I don't think any of these are absolutely perfect. We've just got to keep trying to work on them. And as I say, these are quite structural, and it's up to us to make sure that we don't tick the box from a structural perspective and miss the point from those relationships and trust and that actual learning by doing and that.
Thank you, Rebecca. I'm mindful of the time. I'm mindful of your time too. We are asked to consider the information which you've provided, which we have asked, and we've asked the question, I guess, as to whether we exist or whether we don't, and you've said we do. Clearly, as the bill progresses, we need to know more. So I think Martin will be asking you back, and we can have more questions as the bill goes on, as you give us more information, and we can ask that of you. Are you happy with that? Has anybody got any burning issue at the moment, or are they quite happy to wait for Rebecca to come back on another occasion when we all know a little bit more about it? Okay, Rebecca.
Councillor Wilmot indicated.
Oh, did you indicate, Councillor Wilmot?
Oh, thank you very much, Chair. Thank you. I just wanted a couple of questions. It's about the operation of the ICP. Will it meet in public in each district? I mean, there's been a lot of discussion with the CCG that they didn't go out to the each area to find out what people thought about them and so forth and so forth. And who will be your official accountable body? Well, that's another issue that I think is very, very appropriate at this time. Who is your... And I would like to know if you have made up your mind who the overall chair is going to be. We would all like to know who that certainly is. It would be very, very interesting. Thank you very much.
So the Integrated Care Partnership, the proposal is that it absolutely meets in public. Our Integrated Care System Board already does. The meetings are live streamed, and the proposal is that the Integrated Care Partnership will meet in public, that the papers will be publicly available. So that will be the proposal for that from April of next year. In relation to accountability, the Integrated Care Partnership will be a joint committee of the local authority and the NHS Integrated Care Board. So accountability will be through to those organisations. The NHS Integrated Care Board will ultimately be accountable to NHS England. So the NHS lines of accountability won't change through this. In relation to the chairing of the Integrated Care Partnership, we're currently working through that at the moment. So there are a number of options that we're looking at. It will be locally chaired, and potentially I think we're looking at whether or not there's some sort of joint chair arrangement between an elected member of the County Council, the City Council and the chair of the NHS Integrated Care Board. So we're looking potentially at some sort of joint chairing arrangement.
Thank you very much. Thank you. And I'm sure by the time we see you again in the new year, you'll have some further updates. Thank you very much, Rebecca. If you wish to stay for the next item, you're welcome, but it's Bassett law. You'll disappear. Thank you. Thank you very much. Thank you. Right, so we're moving quickly on to the Children and Emergency Services at Bassett Law Hospital. Jen, are you disappearing? Where? Because I need to see you. Well, I think we need some heating on personally. I understand the windows are open. Good afternoon. Good afternoon. How are you? Just fine. How are you? Welcome, gentlemen, and my apologies. We're running late, as we always do with this committee, because we have so many questions. So my apologies that we're running late. I just want to check here. We have Idris, who I think keeps that seat warm every month. We have David Perdue. Good, hello, and we have Dr. Tim Noble. Excellent. So I've got the right people. So I'm going to hand over to you, Idris, or whoever, to give us a briefing on what your plans are now at Bassett Law.
Thank you, Chair. So I'll just do a brief introduction and then I'll pass on to my colleagues, first David and then Dr. Noble. We've come this month to talk about some significant investment into Bassett Law Hospital. And that will create something which we've commonly called an urgent care village by integrating various urgent care services at the hospital. But critically as well, it helps us with options going forward to manage paediatric care in a different way to what it is currently. And this is one of the key things I'd like the committee's view on, because our intention or suggestion would be that we go to formal consultation with the public and stakeholders with regard to the paediatric service. And we'll describe the context and the reasons sort of for that. And in 2017, and some councillors may remember this, and certainly it was quite well talked about and publicised, was that we unfortunately had to withdraw the paediatric ward, so the overnight stay for paediatrics, from Bassett Law Hospital due to some very significant staffing problems. In the lead up to that, the ward had actually had to be closed on a number of occasions on an ad hoc basis, as particular rotas and shifts couldn't be covered. And you can probably imagine the risks involved in not having nursing staff without notice, simply because of the numbers not being available to recruit. So since that time, 2017, children who have been required to be admitted overnight have been transferred typically to Doncaster Royal Infirmary. Now, some children have always been transferred to both Doncaster Royal Infirmary and, in some cases, to Sheffield Teaching Hospital, and we'll sort of try and separate out some of those numbers for you in a short time. Now, that situation has continued, obviously now for quite some time, partly due to COVID and partly not having had the opportunity previously to come up with a really workable alternative model. We've now carried that situation for the best end of 5 years. We now want to make a more permanent and secure arrangement that would be better, we think, for the public, for the care of children in Bassett Law, and also for the staff involved in the service. Next slide, please. In fact, you can jump 2 slides. That's it. Thanks, Martin. So, Bassett Law paediatric emergency attendance is quite large, over £11,500, and over the last 12 months, we've had 410 children that have been transferred to Doncaster Royal Infirmary. The proposed model that we'll be looking at would significantly reduce that to less than half, so 208 over a 12-month period is our estimate. And my colleagues from Doncaster and Basildon hospitals will be able to go into more detail and ask questions with regard to that. But as I mentioned, we've always transferred a reasonable number of children to the more specialist services, both at Doncaster and Sheffield teaching hospitals. So that 202 is bringing us as near to the position of having a full-blown ward as we, I think, could reasonably hope. It's a very sort of similar level. So obviously, we're very fortunate to have Sheffield Children's Hospital, and I know David will probably mention about the close ties that we are building between the different providers and taking the opportunity of having sort of the Children's Hospital not too far away over in Sheffield. So next slide, Martin. So the emergency village, as I mentioned, is going to be made possible due to very significant investment, £17.6 million. Now, that's probably the largest capital development that the Trust has seen sort of for many years, and certainly from the Basildon population perspective, it is sort of fantastic and welcome news to have that level of investment. And it will both secure and expand urgent care, including A&E. And I know in the past I've spoken to many people in Basildon who've been concerned that they may one day lose their A&E. Well, putting £17.6 million into it, I think hopefully will reassure sort of the local residents. And it will ensure the resilience, therefore, of the entire hospital, and as a strong, vibrant district hospital. So it's not a regional hospital with specialist services and things, but it is a strong local district hospital with urgent care services. And under this new model, we'll be able to care for the vast majority of acutely ill children as well. So I'll pass on to David to talk about the services.
Thank you, Idris. Thank you for the opportunity to come speak to you. So in terms of an emergency village, that will provide same-day services for ambulatory care. So currently the emergency department at Basildon Hospital, we have to transfer patients up to the ambulatory units. So this will provide co-location. And then also what's very popular at the moment is same-day emergency care, called SDEC, and this will give us the opportunity to have a medical, surgical, orthopaedic and gynecological SDEC within the footprint of the emergency department. So when patients do attend, they'll get to the place where they need to, so they receive that treatment much quicker. So this development is support from the clinical teams within the Trust, but also with the primary care networks in Basildon and with the community services, because we want a whole holistic view of kind of the patient when they arrive. So this investment in the existing services will be increased in size and scope. So currently Basildon Hospital's ED was built to deal with 100 patients a day. This year we topped 238 on one day. And on average, that's around over 150 people attend the department. So it's actually future-proofing the department for us. Next slide, please, Martin. So this is I've done that one. Next one, sorry. So this is an artist's impression of what it may look like. The development, the 17.6 million, is the refurbishment of the current emergency footprint, plus a new build which will go into their car park. So that will give us an opportunity to build a new ED whilst the other one is still functions, and then we will change that, which will be the Assessment Treatment Centre, SDEC, will go into that part. Next slide, please. Just in terms of the future model, we've had the opportunity to confirm the future model of urgent emergency care of children at Basildon Hospital. So with our proposed preferred option, children will be able to stay for longer periods of observation, including overnight. So as we've said in the first slide, there's some children, the current model, children, last person to be admitted is 7 p.m. and the unit closes at 10. And some children go to Doncaster quite late in the evening and then discharge the next morning. So it will allow those children all to stay on site, which is really important. So when we've spoken to families as part of some of these discussions, they're really pleased with the services and the services they get within Basildon as a hospital, and then the care they receive in Doncaster. The biggest issue is that they'd like some local facility for overnight stay. So this allows us to do that. So it's an improvement on the current temporary arrangement, reducing those transfers for authorisation to Doncaster Royal Infirmary. So some children will still have to go, but that's always been the case. So children who require high dependency care will have to go to Doncaster, who require emergency surgery will either have to go to Doncaster or Sheffield Children's, and those with tertiary illnesses will still have to be transferred. But it's many more advantages, including modern facilities for patients and their families. So part of that is looking at the decoration, and we will confirm and discuss with local families in terms of what their needs are. So that will include children who've got mental health issues, people with autism, people with learning disabilities. So we get the right environment, the right new lighting, which makes the best environment for the families. Next slide, please. So since 2017, in terms of recruitment, trying to get the specialist registered nurses, paediatric nurses, we have biannual recruitment cycles. So registered nurses come out now from universities at the same time every year. So they're ready to start in September. That's when they qualify, and they then start working between September and October. So we always have a recruitment campaign in the summer, early summer, to try and get people who are being trained to come and work in the organisation. So over the past, we've appointed 12 registered nurses, but unfortunately we've had 10 leavers, and 5 of those are retirements. And over the next 2 years, there's probably another 4 registered nurses who are currently semi-retired who will then go to retire. The COVID-19 pandemic has made that worse in terms of natural attrition. So what we're seeing is that nurses who currently can retire at 55, who would have come back or stayed longer, are actually leaving the profession. But work's ongoing with NHS England and improvements look at overseas recruitment. So we've been very we've had a large number of international nurses join the organisation, and that's been a national campaign, part of Ruth May's campaign for 50,000 additional nurses. An awful lot of that is around international recruitment. So as an organisation, we've been successful in adult nurses, but now we are looking at how we can move that to paediatric nurses. An awful lot of places do train children's nurses. But we're also working locally with our own team to look at increasing paediatric places. So Sheffield Hallam University has put an extra 40 places on for children's nurses. And we're looking at how we increase our placement capacity to get more people to work locally. We are also looking at different roles in terms of nurse associates, which is a different course, which is a 2-year course, and putting that on locally to ensure that we get our local community working within the organisation. Next slide, please, Martin. So in terms of the case for change, the Trust and the CCG are committed to providing accessible services locally, but safety does remain obviously our highest priority. In terms of having a co-located area, so the plans are that the Children's Emergency Department within the new building will be co-located to a children's unit, and then next to children's outpatients. So you'll have a mini children's hospital within Basildon. That co-location means that the staff, especially staff we need, will be less because it can benefit from shared teams across various subspecialities. So since 2017, the Royal College of Paediatrics and Child Health has changed the rules in terms of emergency department. So you also always have to have 2 children's nurses in any emergency department. So that made the situation worse, but this will make it much improved in terms of that co-location. Emergency department census continues to rise, so we need to work differently. And that's both within paediatrics, but also across medicine, especially around frailty. But this new development of facilities will be a way of attracting new staff as well as experienced staff. I'll hand you over to Tim.
I'll put my microphone on. Thank you, Chair. Thank you for giving me the opportunity. So I'm Tim Noble, I'm the Medical Director at the Trust and I'm a consultant adult physician. This is a really exciting opportunity for us. I was involved in setting up the Assessment and Treatment Centre back in 2013 and would have dreamed of this opportunity to co-locate, but the funding wasn't available at that point. So this is a really exciting opportunity to get services together because they work better when they're together. So how did we come up with the options? So if we move on to the next slide, please, Martin. We've had significant support from our colleagues and I work each month with the Children's Hosted Network at the ICS and obviously lots of work with the CCG to come up with a range of possible options. We've taken into account obviously the views of families and service users. We've discounted some options in our considerations because going back to the pre-2017 model is just unachievable. As David has alluded to, the national change in the requirement for paediatric nurses to be on every shift in ED, 2 of them at all times, has drawn on a limited pool of paediatric nurses across the nation. It's well intentioned, but it has a knock-on effect. So for us, the idea of a co-located department was an obvious choice. If we could move on, please, Martin. So our option 1 is to continue as we are. It does work. It's not the best, but it's the best in the safest way we can have. So the assessment unit is open and receives children. The ward isn't particularly close to the ED department, but it's achievable to transfer patients. And then when closure of the department is imminent, we transfer those patients that need to be moved across to Doncaster. And as David has alluded to, there's always been a necessity to transfer children immediately to Sheffield Children's Hospital for certain conditions and to Doncaster Royal Infirmary for certain conditions. We would prefer not to maintain the status quo, especially with the significant funding investment. You'll see I'm a secondary care clinician on paper. If we could move to the next slide, please, Martin. Option 2 is a dedicated children's assessment unit built next to the emergency department using the capital funding that we've described. That would co-locate the services, would have improvements in terms of staffing resilience, but would still close at the same hours and would still necessitate the same number of transfers almost certainly. And again, that's something that we're trying to improve upon. And then if we could move on again, please, Martin. Our third option is to actually have a dedicated children's assessment unit next to the department, which would remain open for 24 hours. There would no longer be a big stretch across the organisation site to get to that facility. Children could be observed for a period of up to 23 hours and be managed in that unit, co-located with the ED. The benefits obviously are there. The improved resilience of staffing. It's easier to shift and share staff around between a co-located unit. People can step in very briefly and out again. And it would reduce the number of transfers considerably. And as Idris has alluded to the figures earlier on. The risks obviously are around how we build it at the time that we're still using it, but David's alluded to that being a separate building adjacent to where we currently are. And obviously there's always an ever-present problem of retirements and people leaving the organisation almost as quickly as they join through recruitment. But our recruitment in the Trust is very strong. We do our level best and are very creative in how to recruit, including the overseas, but it still returns what it returns, and it isn't sufficient for us to go back to a fully open, independent 24-hour ward unless it is co-located. Thank you very much.
Thank you, Tim. So obviously this model is, and the different options are not the same as opening up a standalone independent paediatric ward, and for the reasons that have been described. But it allows, and particularly the final option there, allows children to be looked after pretty much as they were before the ward had to be closed overnight. And that's all about the co-location, using the capital investment, but also providing what David's just described as almost like a mini children's hospital. So, you know, a much improved physical facility, as well as the provision of care over a 24-hour period. It will be covered. And like I say, those children that have always needed to be transferred will continue to be transferred if they're acutely ill and need specialist treatment, surgery. But it will ensure that we can look after the vast majority of children at Bassetlaw. Because this is a sensitive issue with the public, understandably, and we made a commitment as a clinical commissioning group when the ward had to be closed, that if we couldn't find a solution to the staffing issues, that we would do what we could to come up with a new set of permanent options that we would then consult with the public about. And that's what we are proposing to do, so standing by what we'd said originally. So we're not looking to just have a minor engagement thing and things. We are looking at consultation because of the sensitivity and the importance of the issues. But as you've heard, I think from all three of us now, we're actually quite excited about this and about the investment that is taking place. So the engagement and consultation will be through a number of means. Obviously, we'll continue to work with partners, yourselves, the District Council, local community and voluntary service, and representatives of local communities in Sheffield. We will tailor the consultation as we go as well. If issues are raised that we need to adapt that consultation to, then that's what we'll do. If we need to do more work in particular areas of concern, or new areas are highlighted, or new communities sort of wish to have more to say on the issue, then we will allow for that. Next slide, Martin. So 4 streams in terms of the plan: an online survey which will be widely distributed for anybody to complete, engagement sessions with service users and representatives. So for example, when the ward had to be closed, we met with a number of families and different groups personally to go through what their concerns and their issues were and how we could adapt to those. So we will put that back in place as part of this consultation. We'll have that targeted engagement, for example, through telephone or online sort of one-to-one discussions with individuals. And finally, we'll use the more traditional engagement channels and communications, social media, websites, and so on. Next slide, Martin. So the next steps, we envisage a 12-week consultation programme running from the beginning of December to the end of February. That means that feedback and everything will be independently analysed and reported. It will be, it says the CCG, I think in reality it's likely to be the new Integrated Care Board that you've just heard about, and that will take the final decision, because the report will be produced in March, and then it's likely to go to an ICB board meeting, perhaps in April. So consideration of the outcome will be made alongside all the other information that we can gather. I think we would like your views as well about when you would like to hear back from us in terms of the consultation, and then we will hope to put in these changes to services during next financial year. Obviously, it's quite a significant capital build. It's linked in with a number of other changes that David's sort of described, and it's in different stages. So it will take sort of many months. but we envisage that all being carried out next financial year. So I'll stop there, Chair. Thank you.
Thank you, Idris. I've just got one question from Dr. Martin in a minute. You have just, obviously, clearly this is a large project at 17.5 million. So I think we as the committee would agree that it's a major substantial change. You mentioned the consultation finishes on February 22. That's the day of our next meeting, in February, I mean. So our meeting following that is the 29th of March. How would that fit into your schedule?
Probably quite well, actually, Chair, because as I've said, the report will be produced in March, so that should be available.
So that should be great, and particularly if we can have sight of it in advance.
Yes, and you can have sight in that in advance, and it would be in advance, of course, of the Integrated Care Board's decision, which I said is likely to be April at the earliest.
So it would be the meeting of the 29th of March. I think Martin's made a note of that. So, you know, to me, that's quite a detailed brief. Clearly, it will have to go out for consultation. But Councillor Martin just wanted a word, I think.
Yeah, thank you, Chair. Yeah, I mean, it's great news for Bassett Law Hospital. You must be chuffed. It's been going on a long time. We know nationally that paediatric nurses have been difficult to get hold of, and it's a really good solution to the problem to move to co-locate them. And of course, you're going to stop 60% of your patients being transferred over to Doncaster. I mean, one of the other problems with employing paediatric nurses in Bassett Law is because you don't do elective surgery on children there. You tend to send them over to DRI or Sheffield where they specialise in that, which is quite right. So they won't come because they don't get the full scope. That's for the graduates on that side of it. But the other thing is as well, when I read that word emergency village, we talked a little bit about it last time, Idris, after the meeting. And I'm just wondering that you know how you're going to adapt that emergency village to cope with children so they can stay for 24 hours. I'm just wondering if somewhere in your hospital internal reconfigurations, like the assessment unit and the current psychiatric ward that exists now, that you wouldn't be able to spend some of that money on creating some kind of safe zone for psychiatric patients that need 24-hour, 48-hour cover in a more secure area in another part of the hospital, because those areas are going to become redundant, aren't they? And that would greatly help the people in Bassett Law, because then they wouldn't have to come to Mansfield for that 24-hour, 48 psychiatric care. That's just my observation. The other thing is as well, are you going to still keep that bus and the driver then? Because that's been a big expense. Yes.
Okay. Do you want to have the questions and then come back on it all at the end?
Could do. There were 3 questions in there. We'll try and retain them. But yeah.
Councillor Wilmot.
Thank you very much, Chair. Obviously, we'll all welcome an emergency village at a cost of 17.6 million in capital funding. It's a marvellous acquisition to the area. And I'm sure the people will welcome it with open arms if they don't the serious situation then. But as I say, to have the possibility to extend the current same-day emergency provision is marvellous, really, especially around the Bassett Law area, because there are problems in that area. And as you say, you have to been sending so many miles away, and during that journey it can be a problem, and the person can get further seriously ill on the journeys. So to have the service there and available is absolutely magnificent. As far as recruitment and public consultation is concerned, I just hope that you'll go out to really an extensive public consultation to include libraries and community centres and large places where you could have the population come in to say 250 people in a nice room and discuss it, fully, because it's the people do say to me that and lots of things, they don't get as much consultation as they should. It's always consultation by the people who provide the service or whatever, and you know, it's essential that happens. As far as recruitment's concerned, I hope you'll come as far as Nottingham, because there are a lot of medical students in Nottingham. And you know, put out the possibilities of being able to work in a lovely environment and new environment, and you know, great opportunity there. And of course, I want you to also make sure you get to the 18-year-olds in the schools and other smaller colleges, because there are people out there looking for work. And a great opportunity for them. So I hope you will, you know, do well on that in that area. Thank you.
Thank you. And finally, Vice Chairman.
Thank you, Chairman. Yeah, we joked a little, Idris, when you came in about the number of times you've come along to this committee, and I think you've been to every one that I've been at since I was elected in May. But in all seriousness, I think the committee, and I don't want to speak out of turn, but I suspect they would join me in thanking you for coming each time. You give us very detailed and thorough reports, and we do appreciate you taking the time to come here and explain. And we accept we don't always give you an easy time, and yet you still come back. So on a personal note, that is appreciated, and I suspect on behalf of the committee that is appreciated. So thank you. Yeah, just a question now, getting back to more difficult things, having said something so nice. So is there a danger that the original children's unit was closed for the night services because of lack of staffing effectively? Is there a danger we'll spend the 17.5 million and still be in that situation where we aren't able to accommodate the paediatric services overnight because of lack of staffing? Thank you.
Idris.
Thank you, councillors, for that, and for your kind words, councillors. Appreciate it. I'll try and answer some of those directly, and then I know David will be able to expand, perhaps Tim as well. With regard to the ambulance, first of all, it is quite an expensive service. Obviously, we put that in for good reason, but we envisage that the children who will need to be transferred are more likely to be more acutely ill. And therefore we'll be relying more on a full paramedic ambulance service, and indeed for Sheffield Children's Hospital as well, Embrace service, which is a dedicated ambulance service for very acutely ill children, very young children. So we will be reviewing the current ambulance arrangements. With regard to mental health, yes, there is an opportunity, but I'll let David sort of come back to that, and also around staffing. The 17.6 million will support the entire A&E, of course, and another co-location of assessment and treatment. So it's almost an existential question you're asking, because if we get into such a situation that you're describing, actually it calls into question the whole A&E and so on, and that's not what we would envisage. And indeed, the investment that we're putting in will make it more likely that we'll be able to recruit and retain the right staff. And certainly the activity as a commissioner, I believe, justifies, you know, sort of having that level of service at Bassetlaw site. And I think we've got a pretty good model, actually. It's a model that I'd probably commend to lots of other small district hospitals, because it is sustaining good, high quality urgent care services for the vast majority of people in Bassetlaw. And I think that's something we can be proud collectively that we've achieved. But I'll let David come on to the other small specific.
Right. Just in terms of the pathways for children, one of the ones at the moment in terms of needing a CAMS assessment. So if you come in with a mental health issue, part of those have to be seen immediately, but there are children who need a period of reflection. And the current process, unfortunately, is that they go to Doncaster. So this does offer the opportunity for those children to have that period of reflection overnight and then be seen locally. In terms of adults, then the conversations are obviously happening with Notts Healthcare Trust in terms of the mental health facilities within the new emergency village. We have to have a particular room that's got all the, it can't have anything in it, it's got to have 2 doors. So those rooms, obviously if there's one of those in place now, we will have to replace that. But as part of an observation unit, which will be co-located in the department, currently people with mental health needs, if they need that time as adults and need treatment, will obviously remain within a physical health bed for as long as they need that ongoing treatment. So there are opportunities to do things differently within the front door. But absolutely for children, that's completely part of it, that they will remain on site. Just in terms of all the co-location, like Idris has said, that means in terms of the investment needs to have some value for money. So part of that is obviously looking at the staffing models and how we make that better. Obviously, as we've got quite a while before it opens, so we've got lots of opportunity in terms of more active recruitment. And as you said, the ability to rotate through an emergency department into a ward environment, into an outpatient environment is quite an attractive thing, especially for newly qualified nurses. And moving ICSs, it does give us that opportunity, because most of our trainees are, as I say, from Sheffield Hallam University, but does give us the opportunity to work with other higher educational institutions to look at actually, do we offer placements to Nottingham, because we don't currently. So there are different options in terms of that recruitment, but it will absolutely be dependent on recruitment. But we will have a really good idea in terms of what we've got, because we know what we need in terms of numbers. We will know where we are, and it may be that we do this incrementally, but the option is there. Our preferred option is obviously to open it 24/7.
Thank you. Thank you very much. Can I ask the committee members, please, if you do consider the proposed change a substantial variation of service, in which case you will be going out to consultation. Sounds quite exciting for you all up there. And we will see you back on the 29th of March with more exciting plans and information of where you are. And I must concur with the Vice Chairman. Thank you, Idris. You really do come and see us quite a lot, and sometimes it's not easy, but I hope we've given you an easy ride today. And thank you to both of you. So, members, that completes the meeting. Thank you very much. We've got the work programme, but on January the 4th, when we resume after the Christmas festivities, we shall be looking at tomorrow's NUH and NUH Maternity Services Improvement Plan. So, yes.
Is that right at this moment? And I'm not quite sure, this isn't related to you, I'm not quite sure whether
I did wonder whether another question was coming. No. Bye-bye. Bye. Have a nice Christmas. Bye-bye.
I totally get how difficult it is to manage the vaccination programme. It's a moving target. The times keep changing, the dates keep changing, and everything's difficult. But in my area, which is North Rushcliffe, there's a lot of confusion about where people can get vaccinations and when they should be getting vaccinations. The current place seems to be to go to Forest Fields, which is quite difficult for people in West Bridgford. I appreciate, compared to being in the villages, it's not, but it is still 2 buses. So I wonder if it's possible, and it might be all over and done with by January, but whether it might be possible to have a review with the NHS of where these vaccination centres are. I mean, I believe there are new ones opening, and I appreciate it's a moving target and it's difficult, but I think there is a problem.
Yeah, I mean, I'm happy, and our members happy to include it. I think we're in a moving feast with it. One day we're told one thing and the next week we're told another. And I think what has happened, and I did speak to Jonathan about it, I think what happened is when we all had the vaccinations in the beginning, there were all these big places open and people were pouring in and it was all highly organised, but they were getting through the numbers. Now those places have closed and we've gone to smaller places and people can't get in. That's one of the problems. It is in the Newark area, and he was aware of this. And I've seen paper reports about it, that people can't get. I think there needs to be some clarification as we go into the next year, because we're not leaving. It's not leaving us, and so we've got to live with it, presumably. Yes, Michelle.
Actually, on the same subject, and really quickly, clinically vulnerable people that are classed as clinically vulnerable are struggling to get vaccination appointments and therefore being told to go into a walk-in centre. Forest Fields, for example, is only, I say only because it sounds like a lot, are only doing 200 walk-in appointments a day, which means by midday they've got no more walk-in appointments available. So vulnerable people are queuing up now, essentially in the cold, clinically vulnerable, not able to get an appointment till the end of December now, it's 20th of December, and they can't get an appointment at the walk-in centre, and they don't make that publicly available that there are only 200 appointments. So they're literally getting to the person in the queue and say, sorry, no more today. And that's happening at 1 o'clock in the afternoon. And I don't think many people know about that.
Martin will
I think
speak to Jonathan about it. We'll try and pull it in. But I think one of the problems is they've closed the big vaccination centres down, and it's limited the amount of people that can get through per day, certainly in my area. Yes, David.
Do you use your microphone? Councillor Moffat,
Can you use your microphone? Can't hear you.
Do you think we should have a paper on the impact of the Adult Health and Social Care Bill that was passed in government yesterday?
I just remembered we've forgotten to ask Richard to turn the live.
We're still having an item, Chairman.
Oh yes, of course, we're on work plan. Yes, sorry.
So the impact of the Adult Health and Social Care Bill that was passed yesterday.